Members, welcome to our Health Committee this morning. Can I first of all remind members of the protocols surrounding electronic equipment and ask them to make sure that their phones especially are turned off, as it interferes with the recording and the Hansard. We have no members of the public in as yet, so I don't need to remind them of the protocols. Can we start then with our first item on our agenda, which is apologies. I note that everybody is present, so therefore we don't have any of those. Item number 2 is the draft minutes of the meeting of Thursday the 22nd of September 2016. Can I refer members to pages 5 to 7 of your meeting pack. Are members content with these minutes?
Yeah.
Yes. Thank you, members. Okay, item number 3 is chairperson's business. I have one item under chairperson's business, and I know Paula will know of this. Was it Tuesday? We had, or Monday it was, Monday, sorry. We had Positive Futures here in the Senate chamber, and I had to respond on behalf of the Health Committee. And Catherine, you actually attended that also. We had people in, and it was to do with autism, autism spectrum disorder, brain injury, and learning disabilities, and they were lobbying for a more joined up and responsive approach to services. So in the particular session I responded to centred on the campaign for the introduction of a care bill similar to legislation being introduced in Scotland and the Care Act in 2014, which was passed at Westminster. I undertook that I would bring this back to committee, and so therefore I propose that we write to the Minister to inquire what her assessment is of the impact of the Care Act 2014 and to ask what consideration she has given or giving to new legislation. I've also undertaken to raise with officials during relevant briefings the consistency of service provision across the 5 trusts and implementation of the Bamford recommendations in respect of learning difficulties. I know that we have had discussions in here to do with the Western Trust has been brought up, to do with the disparity there in services with people with learning disabilities and learning difficulties. So I just, on a personal level, it was really quite eye-opening, some of the statements that were said, and all too often we can continue through our committee and through our committee briefings and make decisions and do things, but to hear from actual human beings of what they're having to live through, and especially older carers, which is something I think that is going to become more and more problematic, and the millions of pounds that they save our health service every year, and yet they're not given a lot of help, and they're not given they don't want recognition, they just want help, and they want services. I don't know, Paula or Catherine, if you want to say anything. I know you both attended it, and it was a really worthwhile event, and we did promise, and I did on behalf of the committee, that this was an issue that we would bring back to committee and further investigate.
I think another issue that was very impacted was around the domiciliary care, in terms of the amount of the problems that the Positive Futures organisation, for example, are facing regarding keeping up with living wage. They support living wage, but it's the funding, and I think that's nearly a crisis point too. I think that's, if they withdrew their goodwill and their services, I think the health service would be in an awful lot of trouble.
Absolutely.
Yeah, and just to say, I mean, one of the parents that spoke, his story really touched me, and in particular, he made a point that he wasn't actually fully aware of all the support and services that were out there for him to access. And I think it's important that where we have parents who are dealing with children with additional or special needs, that we ensure that the full range of support and services is made known to them as soon as possible, because it's stressful enough.
No, absolutely. So are members in agreement with what I have suggested, that we write to the Minister on those specific issues? And I think it's just another thing within this committee that we need to keep abreast of and keep on top of, because we know there are serious problems out there. Just now that I see the members' gallery is full, which is great, you're all very welcome. Can I just advise you that all mobile phones must be on mute, and you can use the Assembly Wi-Fi if you want to. You're not allowed to record either, and no photographs. So just thank you all for being here. It's great to see it full. Okay, members, if we want to move on then to item number 4, which is our briefing from the Northern Ireland Ambulance Service and the Northern Ireland Fire and Rescue Service. I advise members that the Chief Executive of the Northern Ireland Ambulance Service Trust, the Chief Fire Officer and their colleagues are here today to brief the committee on the work of their organisation, including current work streams and priorities. I advise members that a copy of the presentation by the Chief Executive of the Northern Ireland Ambulance Service is at page 10 to 23 of the meeting pack, and other relevant papers are at pages 24 to 197. The Chief Fire Officer's paper can be found at pages 3 to 7 of the tabled pack, and the annual report of the Fire and Rescue Service is at page 198 of your meeting pack. So first of all, can I welcome Mrs Roisin O'Hara, Interim Chief Executive of the Northern Ireland Ambulance Service, Mr Brian McNeill, Director of Operations of the Northern Ireland Ambulance Service, Mr Dale Ashford, Interim Chief Fire Officer of the Northern Ireland Fire and Rescue Service, and Mr Gary Thompson, Assistant Chief Officer of the Northern Ireland Fire and Rescue Service. So thank you, you're very welcome. I'm glad I got a mouthful out of the way. It'll be first names from now on. So I don't know which one of you want to do your presentation first. It's up to yourselves. Dale, do you want to? Or, yep. You decide? Okay, go ahead. Okay, thank you.
Madam Chair and committee members, thank you very much for giving me the opportunity to come today to talk to you about our service and some of the challenges and pressures that we're experiencing, and hopefully also some of the suggestions we have for how to improve things as we move forward. You'll see from the presentation that I've split it into 3 areas. So we're going to look at the workforce, we're going to look at the performance against our Category A target. Our Category A target is our target that's an 8-minute response towards those patients who have life-threatening conditions, and we'll look at clinical performance then. In terms of our current situation, we've 1,287 funded establishment, and out of that we've just over 1,000 frontline staff, and they would be the staff that respond to the 999 calls and that you'll see go out in the ambulances or to go out in the cars, the rapid response paramedics as well. In the last year, we had a big recruitment campaign and we managed to recruit 203 frontline jobs, and that's put us in a very good position as we go on to meet some of the challenges that are ahead of us in the incoming years and year. Each year we actually invest about £2 million of our budget in clinical training interventions. So we spend a lot of time identifying with our clinical stakeholders what the key aspects of that are for our staff, our clinical staff, and we make that investment in them. And I'm pleased to say that this year, in the first quarter, and as we go on through to August figures, we appear to be on track to meet the departmental target on sickness absence, which is a 5% reduction from where we were last year. So we're on track for that, although I would have to say that the sickness absence is still high within the ambulance service, and it's something that's a priority for us and we'll continue to look at. The vacancies, I thought, because there has been some media attention, particularly over the summer, and I thought it might be useful just to take a moment or two to talk about the recruitments that have happened and that are ongoing. So in terms of our paramedic workforce and our patient care services workforce, all the recruitments have completed and all the posts are actually either offered or in the process of being offered. So we will be in a position very soon where we have no paramedic vacancies and we won't have any patient care services vacancies. We still have about 61 EMT vacancies. Now, as the detail I'm giving you is as of today, because obviously vacancies, people will leave, people will retire, etc., and they'll shape every day. And also sometimes when we appoint a paramedic, we draw that from our technician workforce, so that creates another vacancy when there's a career progression opportunity. So at this point in time, we have about 61 vacancies in our emergency medical technician workforce. The recruitment processes are in progress. Some of them have completed. There's been a recruitment for qualified technicians, and that's the offers of employment are about to be made on that. And we have 2 cohorts of EMTs planned for this year, so that will bring in about 50 more EMTs, emergency medical technicians in this current year. So we're hopeful that we'll be in a strong position in relation to the workforce and the stability within the workforce by the end of this financial year, and we hope to build on that as well. Some of the key issues that we have, I've outlined in the presentation. We're still awaiting the outcome of the job evaluation for our paramedic workforce, our paramedics who are our rapid response vehicle people, and our emergency medical technician posts. This process has sat outside the Trust for a couple of years now, and we still continue to press the job evaluation leads on the Department of Health side and also on the trade union side to bring that to resolution, and we're hopeful that we'll get to an outcome of that, because the Trust would like our staff to have that process finished and to know where that has landed through due process and in partnership, and that would be very important to us all. We're moving out now to actually develop a staff engagement strategy for the Trust, and we're doing that in the first instance by starting staff engagement. So we have met with staff throughout the organisation on our new corporate plan, which is due to go live on the 1st of April next year. So we're using that as a jumping board to actually talk to staff about what's important to them in terms of what we do, what success looks like to them, and how we would measure and demonstrate what that success is like. So this is a new type of process that we're doing within our service, and hopefully through that there'll be some programmes such as we've just implemented a health and wellbeing focus group that's a partnership group with staff, with trade unions and with management that are looking at some of the issues around that as part of the staff engagement. We also this year are looking at a new programme of education. So historically, the programmes, the national programmes that we used are all being reshaped. So we have now moved out with new driving training for both the emergency response and the ambulance driving. We're moving out with a new programme for a regulated programme for our emergency medical technicians. And although we've no paramedic vacancies, we're using this year to further look at and establish opportunities for paramedic education. We're in discussions with Department of Health colleagues in relation to university-type education and that as well. There's lots of options there, and we need to make sure we get the right one for Northern Ireland in that. Okay, then moving on from the workforce to go into the NIAS frontline activity and performance. It'll be no surprise, I think, to Health Committee that we have not met our Category A 8-minute target for some time now. The last time we met it was in 2011. Last year we achieved 53.5% of the Category A target. However, we are getting there in an average of 10 minutes. And we do better in some areas. For example, again, it will be no surprise that within the Belfast area, the big city area, it's an average of around 8 minutes. The rural areas provide more difficulty in terms of actually getting the ambulance to the patient within that 8-minute slot. But in total last year, the service managed to get to patients in around that 10-minute slot. And I have to say, when we get to the patients, our staff are very clinically sound, and we've got some very good clinical audit data that shows that we're up there with the other ambulance services nationally, and that we're doing a good job clinically. We do remain committed to getting to those most clinically urgent patients as quickly as possible. So those with immediate life-threatening conditions will continue to be our key priority, and we need to make sure that all our systems support that and get us to those patients. We've had a lot of performance challenges from 2011 and 12 when we last met the target. The Northern Ireland population has increased by 2.1%. Our own demand for Category A, which is our life-threatening demand, has risen by 23.1%, and our performance has fallen by 19.2% in that period of time. Our commissioned hours have increased by 7.1%, and our frontline workforce has increased by 3.4%. So it would take me a long time to go into the detail of that, but I think really there has been certain productivity gains within that, and although we're not meeting the target, and we all would prefer that we were, we have actually managed that increase in demand, and it's been a significant increase in demand that we've been struggling with over that period of time. So an example of that would be that during July this year, NIAS responded to 40 extra calls a day. So that's quite a substantive amount of extra calls for our staff to be responding to in an average day. Some of the other challenges that we've had from that period was the changes in the wider system. And I think, again, you'll be aware that when there's changes in some of the big acute hospitals, there could well be an impact on the ambulance service. So we have supported a lot of the HSE service modernisation. There's been changes in Downpatrick, Lagan Valley, Mid-Ulster, Omagh and Belfast City Hospital during that same period of time. So we've been managing to support those trusts and the service as a whole in that regard. We do have some issue in relation to long hospital turnaround times, and we believe that equates to about 6 ambulances a day that we lose in relation to the handover at hospitals. Now, we are working with the hospitals and with our commissioners in that regard, and we'll continue to do that, and we need to find a solution for that. But that's the reality that we're working with as we sit here today. We also are experiencing longer scene times with patients due to an enhanced care provision. And in the clinical bit, I'll go on a little bit more to talk about our alternative care pathways. But when we're starting to treat people at home and leave people at home, that can prolong the length of time that our clinicians stay with the person at their home. So we're seeing some of that as well, maybe impacting on it. Winter's always been a difficult time for the ambulance service. You would think it didn't happen every year, but it does bring its pressures, particularly heavy snowfalls and flooding or whatever. It does bring pressures, so that continues to be a pressure for us. The other thing that we have is the significant major incidents, and thank goodness they usually don't land as such. So if I could use an example of an airport alert. So on a regular basis, we would have airport alerts where our ambulances and RRV paramedics and officers would have to go to an airport. And thankfully, none of the planes have actually crashed, or it's never come to fruition. But it does take a lot of our staff out to these major incidents, and then they have to regroup and go back to their day-to-day job after that. So there's that dynamic as well, which is a performance challenge for us. But again, we are talking to Department of Health colleagues, we're talking to our commissioners, we're talking to other trusts. We're all part of a big system in relation to trying to resolve some of these issues. In terms of the priority service developments that we believe would help in relation to that side of the house, we are very keen to commence a capacity review. We've got some support from the commissioners in that and from the Department of Health. We have benchmarked what's happening, particularly in Wales and Scotland in that regard, and England as well are looking at their capacity and some of the issues there as well. So we're hopeful that we'll get through the whole procurement and be able to head out on a capacity review this side of Christmas. We'd certainly be hopeful by the end of October if we can get procurement finalised that we'd be able to go out. That then will give us a better idea of what we can do best with the resources we have and what we would need to meet the ministerial target. And then we can start some, discussions, brave discussions at that point as to the shape of the service, what we need in the service, how we best deploy our staff. Moving on then to the clinical performance and the priorities there. We are involved, and indeed we chair the Community Resuscitation Strategy Implementation Group, and we work with stakeholders from all around, and the public sector and the public, and our colleagues as well, in relation to a lot of the very good stuff that we're doing and moving that forward. So from an ambulance point of view, we've been involved in training staff in CPR and use of defibs, in creating more of a momentum around public access defibrillators. We are going to be involved in October in a Start a Heart day, where we're hoping to have a lot of media and hoping to use events in order to get the public. We're hoping about 5,000 people will pay attention and learn how to use the defib, how to start the hearts, etc. We also have identified where a lot of the community defibrillators are, and we now, when you ring through to our control room, if it's a cardiac situation that you're reporting, we'll be able to tell you where the closest defib is if that's of any use to you. We also have commenced several first responder schemes. You may be aware of some of them, most recently with my colleague here and our fire and rescue service, which has been going very well, and I'll let Dale continue to do a little bit more input on that. So we're doing a lot on that, and that's very proud of our involvement in that, and it is about collaboration with others and collaboration with the community to make a difference to people in need. We also have started the primary PCI, which is really about fast-tracking patients who need stenting and with cardiac issues to the cath labs. There's 2 cath labs in Northern Ireland, as you will be aware, one in the Royal Victoria Hospital and one in Nagelvin Hospital. And we've had very good success. Our clinical audit has shown that we're doing very well on that, and indeed meeting the targets that have been set for us in that regard. And we also have a fast track to stroke services as well, and again in terms of patient outcomes that again is very positive and very important. Alternative care pathways I've mentioned already. I'm going to go on to talk a little bit more about that, so we'll park that for the minute. And I just wanted, our medical director would never forgive me if I didn't mention the electronic patient report form. You know, we are on a paper-based system at this point in time, and we really need the support to move it to an electronic basis. That would make such a difference to us, particularly in our clinical audit, and knowing the outcome of the patient, because once we hand over to hospital, etc., you know, our data in essence it stops then. But if there was an electronic link, then we would have very meaningful information, and it would help us whenever we're thinking about our targets, our patient outcomes, our patient experience, etc. as well. And it also provides for more synergy within the service as a whole. So, you know, at this point in time, our ambulances will ring the ED department and describe and the ED department will put it in a book, whereas if there was an electronic patient report form, that would all be seamless and everybody would access the same thing. So it's a priority for us. Going back to the alternative care pathways, you'll know historically the ambulance service has been about responding to people in need, putting them in the ambulance and getting them as quickly to hospital as we can. But the situation has changed, and the clinicians and the clinical training that has supported our people in moving forward has changed dramatically. So we're now at a point where we're actually looking at hear and treat and leave, and treat and refer models. Over the last 2 years, we brought in 10 alternative care pathways in partnership with the other healthcare trusts, and these are working very well. There's new pathways for people who are diabetic, for palliative care. We have BCH Direct, where we can directly bring somebody who meets the criteria, usually elderly, straight through to Belfast City Hospital. I myself has been a personal user of that. It's worked very, very well. So there's lots of that going on. There's 10 new interventions in there. So in year 15-16, there was 7,000 of our contacts that did not go to the ED department. Out of that, there was over 1,300 that accessed some of these new alternative care pathways that have been set up, and others may have been hear and treat. We have GPs in control now, and they'll be able to, if it's appropriate, they'll be able to talk to you and deal with your issues then, ring you back and see whether it needs escalated up to an ambulance response or whatever. So that's all working very well. That is very good, I think, for, as long as that's appropriate, and we believe it is, that's very good for the patient and their carers. It's also good for the ambulance service, because then it does release a resource to go to the next person in need. So that's very useful to us as well. So going on to the financial position, we have demonstrated year on year sound financial management, and again we're predicting a break-even position at the end of March. However, I have to say that finances continue to be a challenge, and we continue to work with our commissioners through the board and the department in assessing future service delivery requirements. Again, with more savings, as I assume, coming on the horizon, it again becomes a more difficult environment within which we can embed projects, we can transform, etc. within that. So it is a pressure for us, and it's something that we take very seriously in trying to protect the front line whenever we're making these decisions. So I wanted just to finish as to maybe what the key things that I think would be important for Health Committee to understand in terms of where we see our priority in moving forward. We want to continue and to develop more being patient-centred and have that as the focus of the provision of our safe, effective, quality care within our available resources. And that's where our capacity review is extremely important. Also advances in technology that can help with the clinical aspect of what we do as well is very important as well. We want to play a full and influential role in shaping and delivering healthcare in Northern Ireland. And we are a small trust, but we're very important. And you'll see us on your streets, and we will make a difference to the bigger trusts in terms of what we can do and how we can work that system before it actually gets into the hospital. And also the other side of our business, in terms of discharges from hospital and keeping the system working and all that kind of thing, is also another hugely important bit of which we do. Our emergency side of the house equates for about 30% of what we do, so there's a whole other 70% that we do that isn't about that 8-minute response, and some of that we do extremely well as well. One of the things that's very important to us, and other ambulance services nationally are moving towards this, is to review the targets, to include meaningful response times, but also to include patient outcomes. So our target at the minute is about a speed of response, which is hugely important if you're in that life-threatening position. But if that's not the case, there's other responses that are equally important, and patient outcome is equally important. So we need to make sure that when you are in a immediately life-threatening condition, we get you the right clinical resource, we get you the right vehicle that's going to take you to hospital, and it's not just dispatching anything to anybody. It has to be triaged sensibly, and the targets need to reflect that. And I also have to say that if we can get the targets right, I hope then the workforce will understand that they are doing a great job. They all work very hard in very difficult circumstances, and hopefully then they'll be able to see that when we report at Trust Board, when we report through as well, because the other bits that they do within that will be also acknowledged and recognised in that. One of the things then, moving on to the workforce, we've already started discussions with the Department of Health colleagues, and hopefully we'll be embarking on a workforce review. It's some time from we've done a strategic review, and we're very excited and very supportive of now looking at a workforce review for the ambulance service in Northern Ireland. Thank you, Madam Chair.
Thank you, rushing. Aill, do you want to?
I've got next. Okay. Madam Chair, committee members, thank you for the opportunity to brief the Health Committee on the Northern Ireland Fire and Rescue Service. Before I talk about some of our challenges and priorities, I'd like to provide a little bit of background, if I may. NIFRS is geographically the largest service in Ireland and the second largest fire and rescue service in the UK. We have some 2,200 employees, comprising operational and support staff. Our people provide a top-class service operating from 68 fire stations, and we're the only UK service with a European land border, and we have arrangements in place to facilitate cooperation across that border. The role of the Fire and Rescue Service has changed significantly over recent years. We deliver a wide range of high-quality services to the public of Northern Ireland, including responding to fires, road traffic collisions and other emergencies. These include such as chemical, biological, radiological or nuclear incidents. Thankfully not many nuclear incidents, I'm glad to say. Search and rescue incidents, serious flooding and serious transport incidents. We are very proud of the consistently high satisfaction rating which we have received from the community of Northern Ireland. Nationally, the English Fire and Rescue Service has moved into the Home Office. This is necessitating major changes in the national governance arrangements and the structure of the Chief Fire Officers Association. It is likely to affect national resilience arrangements, and we are engaging with national colleagues to ensure that we continue to play our role in the national resilience framework. As a fire and rescue service, we face a number of challenges. The current corporate management team have faced and are addressing a number of issues, including dealing with modernising the service. We have looked at our operating model and are dealing with governance and infrastructure issues, all within a very challenging financial environment. A large proportion of our operational staff are retained community firefighters. These men and women provide an excellent service to the communities they serve. However, the changes in demographics and the working trends in Northern Ireland present challenges in maintaining retained availability. We have recently introduced an electronic monitoring system to help us gain a clear understanding of availability on a 24-hour basis and to help us inform operational and recruitment decisions. Like most public sector organisations in recent years, we have faced financial challenges. Our budget is currently a total of around £73 million. We are currently facing revenue budget pressure and working through a savings plan to address this. In determining our efficiencies plan, we have based decisions upon 3 specific criteria, namely public safety, firefighter safety and the well-being of our people. We compare well with our UK colleagues in terms of value for money. Our cost per head of population is below the national average. However, we are seeking to introduce different shift patterns and a new careering framework that will help us make even better use of our resources. Our new operating model will be based upon risk and will complement our integrated risk management plan to get the right resources in the right place at the right time. The effective introduction of this model will require us to recruit for 2017 if we are to manage overtime efficiently and deliver the level of service that we need to provide. Capital priorities for this year include a new logistics support centre, for which enabling works are already underway, and the development of our IT infrastructure, for which we are operating in partnership with BSO. The replacement of our incident command and control system is ongoing as part of a joint procurement with Scotland Fire and Rescue Service. The process of modernising much of our service is likely to incur increased revenue costs in the future. For instance, the maintenance of the upgraded wide area network and improved infrastructure may be more costly than it is currently. NIFRS is undergoing significant change. This is an exciting time, but it's not without its difficulties. Organisational structure reviews are at various stages of development for all of the HQ directorates, and a major piece of work in relation to the wider organisational structure is well advanced, and the first draft has been presented to the board. NIFRS makes decisions in relation to service delivery based upon risk assessment, and this resource to risk approach has resulted in the proposed relocation of a number of our whole-time resources. We are looking at innovative solutions to enable us to provide our service in the most efficient way possible. We have progressed a long way with changes such as alternate crewing, and by the end of the year we hope to be well advanced in the implementation of our resource to risk programme. This will see us changing 6 stations from variable crewed stations, which operate on 2 watches 7 days per week, to a more efficient day crewed station, which is 1 watch 5 days per week. We will also be introducing whole-time day crewed stations in Duncannon, Downpatrick, Strabane and Enniskillen, where a pilot is already in progress. The introduction of 4 new whole-time stations will improve the level of service delivery, making the best use of our existing resources. We have recently launched consultation for our Integrated Risk Management Plan, our IRMP, which sets out the strategic direction for delivery of the service. New fit-for-purpose emergency response standards are being progressed and will go for consultation later this year. We are working with our colleagues in NIAS on a co-responding pilot in Lurgan. This will involve ourselves and NIAS being mobilised simultaneously to certain categories of call, in particular cardiac arrests and chest pains, in an effort to improve attendance times and patient care. This is part of an approach that has been endorsed nationally by the National Joint Council and supports the community resuscitation strategy that Roisin has already mentioned. As well as the co-responding element, we are also looking at wider collaboration with the Department of Health across a range of areas. These include upstream prevention in the wider sense, i.e. not just fire prevention, utilisation of our estate, and looking at further opportunities for working together. A working group chaired by the Department of Health has been set up to take this forward. NIFRS has introduced a new people at risk strategy to ensure our resources are targeted to those most at risk in our community. A key element of this approach is partnership working, and from the 1st of April this year we have signed 41 partnership agreements with statutory, voluntary and community organisations, including a number within the health and social care sector, to signpost vulnerable people and help protect them from accidental fires. We are statutory partners in the community planning environment with the new councils, and we also play an active role in the policing and community safety partnerships. This is an area which will develop over the coming year and will provide us with an opportunity to enhance our partnership working. It will also provide a platform for prevention interventions to help ensure positive outcomes for the community. We are currently reviewing our youth engagement interventions and programmes to ensure the most efficient use of our resources. We've recently signed a 3-year agreement with the Prince's Trust to deliver a number of their programmes across Northern Ireland. We continue to deliver a very positive Fire Cadets programme based upon the national model, but it's worth pointing out that the delivery of these initiatives is entirely dependent on our ability to finance them from within our budget. Our new training centre is at OBC 2 stage as part of the wider Northern Ireland Community Safety College programme. Approval has been given for the early works and money has been secured. The design team for the enabling works has been appointed and work should be underway during 2017 on the building of a new tactical firefighting facility, with completion of that phase by spring 2018. A significant amount of risk will be mitigated for us with the provision of updated training facilities in a real firefighting environment. Overall, we're happy to report that there has been a reduction in emergency mobilisations. We've worked very hard on the prevention agenda over the last 10 years, and the benefits are showing. In 2015-16, we responded to 22,458 emergency incidents. Of these, 3,200 were classified as major fires. However, it's worth pointing out that there were 12 accidental fire deaths, which shows the need for us to maintain the emphasis on the prevention and protection agenda. We also rescued 561 people from road traffic collisions, and we continue to work with partner agencies to develop a new road safety strategy, which we plan to go to consultation with early in the next year. Given the importance of the emphasis on prevention and protection work and our reducing budgets, we are looking for more innovative approaches such as the use of volunteers and increasing our partnership working to help us achieve positive outcomes for the community. The introduction of the Fire and Rescue Services Emergencies Order in 2011 required us to develop new capabilities in relation to flooding, serious transport incidents, urban search and rescue, and chemical, biological, radiation and nuclear incidents. The types of call that we get are changing. Climate change is having an effect, and we get more flooding calls now than we ever did, and rural firefighting is a significant issue. We are called upon to provide specialist technical services such as specialist rescue, flood, rope, collapsed structures, etc., and there are emerging international security threats. The civil contingencies environment has also changed significantly with the introduction of the sub-regional emergency planning groups, and we play an active part in these groups and sit on the civil contingencies group for Northern Ireland. So to summarise, as we look to the future, we will continue to explore more effective and efficient ways of working. We will continue to balance how we make savings and provide value for money against the very real need to invest in our personnel and our infrastructure. We're committed to seeking innovative solutions to service delivery, which will ensure that resources are adequately matched to the changing risk profile of our local communities. We are targeting our prevention and protection messages to ensure that we reach and protect the most vulnerable people. We see great potential in the collaborative working and data sharing that will bring real benefits to the communities we serve. However, none of this would be possible without the people who work for NIFRS. They are undoubtedly our greatest strength, and I want to pay a personal tribute to all of our people who have fulfilled all of their duties and served their communities with the utmost dedication, despite some of the challenges we face. Thank you, Chair.
Thank you, Dale. And thank you again for your briefing. I have a list. I have Ian, Trevor, Gary, Joanne, Robbie, Paula, Jerry, Pat and Catherine. That's just for your information, folks. Anybody else wants to put in? There you go, Mark as well now. So you've got a full list of people who want to know a little bit more information or ask some more questions. I have a few questions for both of you as well. I'll start off with you, Roisin, and it's probably want to look at the challenges ahead, because we know all services within the health service have to adapt to whatever direction healthcare goes in the future, and I know that's going to pose great challenges for you also. I was really encouraged to hear about these pathways.
Yes.
And that's making such a difference, I'd imagine, to the backlog within our emergency departments.
Yes, and it can be built on and developed on, and we're very pleased with the evaluations that we're having now, both in terms of the people that aren't going to the ED department, but also that it's appropriate that they don't, and that they're accessing the treatment where they need to access it. So that's something we'd certainly be very keen to build on with our colleagues.
And that's why I can understand why electronic recording and information passing. We've talked about this in the last mandate to do with general electronic recording and information sharing, and I think again within your service that is bound to be, a really important facet of going to an emergency call is having that information and knowing, the patient's history even, or because quite often you would be going to something as well where a member of the public has telephoned, so you have no history whatsoever of what that patient may have. So electronic sharing, even more than recording, could be of great benefit for a professional service moving forward.
Yeah, and it hits a range of areas for us, so absolutely for that, but also in terms of our clinical education and clinical supervision, to actually be able to then allow the paramedic to look at what they're, quickly to access the patients that they've dealt with, to reflect on their clinical practice, to look at improvements on that, etc. So there's lots of ways that this will improve our service, so it's a key priority for us, absolutely.
I suppose then with the handover as well, it's quite disturbing that in this day and age that it's a piece of paper or recorded in a book, a handover from the ambulance service in the ED department. Kind of would have thought by now that we'd have something a little bit more technical than that.
Yes.
And also want to bring up, you talked about 6 hours, or six ambulances lost per day, is that?
Yes.
Through the backlog at our ED departments and not being able to do their handover, I assume that is.
Sure, if you wanted to get our Director of Operations to maybe talk a little bit more on that particular issue.
Yes, it is still an ongoing issue for us, though I have to say the work we've been doing with hospitals, we have reduced the longer waiting times and our queue times at hospitals, so the days of 2 hours are more of exception now than the norm. So again, I have to recognise the board have supported us in funding HALOs, Hospital Ambulance Liaison Officers. in the main hospital emergency departments, and these are ambulance staff, paramedic qualified, who work with the team both in prioritising patients coming in, but also working out ways collaboratively of trying to fast track patients through and reduce congestion, and that has had a very positive effect. But I guess the reality is it's a symptom of general increase in demand, and there is no quick fix. It's something that's pandemic throughout the whole of the UK. But I suppose we're grateful in terms of both the EDs themselves. We have a very good working relationship, so it's all about the patient and trying to resolve that. And again, you mentioned electronic patient report forms. That would be useful in terms of auditing these things, getting the evidence to support where changes could be made that wouldn't adversely impact on the patient. There's no quick solution, but we're certainly looking at every conceivable possible way of addressing it.
Yeah, I think sometimes some of the most simplest innovative ways of working can make the biggest differences. And I know I've worked in an ED department. I know the value placed upon yourselves, and I know the absolute frustration as well, where they want to get on with their job and get out there and do their job, and that's being hindered. So any progress, and I know that there has been progress made, and I really welcome that, but I think that there's a lot to do. Mark, did you want to come in that point?
Just come on, and I was just wondering, is this problem particularly pronounced in any area, or is it general right across in our? If you could use the term, the best performing ED is actually Altnagelvin, because of the way it's structured and the volume, the number of patients going through it. The pressures are, as you would imagine, the big EDs, the Ulster and the Royal. But is there something that can be learned from the model?
No, it's not that simple. It's really not that simple. It's really got to do with the number of people who present themselves, and we don't bring all patients to EDs, though some people think we do. We have quite a lot of patients who self-present, and we're in competition with them, and that really is, there's that area of the demand flow has to be looked at, and that would help, but there's no transferable solution.
Okay, thanks, Mark. Just want to go on to workforce planning. I know in the last mandate as well we had looked a lot at workforce planning. I mean, there are many crises amongst various parts of the health service. You had mentioned about your workforce planning and that there are now no vacancies within the paramedic.
No paramedic vacancies as we sit today. Yes.
So how do you see that as we go forward with the direction that we want to see in health going, and your workforce, will your workforce have to adapt, have to change? Any funding model or funding that needs to be different?
Yes. I think, my gut feel at this point, at the beginning of this capacity review, is that if you look at other ambulance services in Wales and the Republic of Ireland, etc., I think you would find that, the capacity reviews have indicated a need for more staff. So we may well just have got to the point of having no vacancies. And if a capacity review indicates a requirement for more staff, we may be back into a recruitment campaign in the new year, if that's the outcome of it. So it won't stand still, I guess, is the thing. But if we get to the point where we're at full establishment, then I think it's about the scope of practice and what we need within Northern Ireland, particularly in the paramedic workforce, supported then by the technician, the emergency medical technician workforce. So I think, when we look nationally, for example, and can see, discussions on paramedic practitioners, we need to start to think of exactly what the need is for the clinician within the Northern Ireland context and start to develop towards that. We also need to be, clinical interventions so rapidly change and advance, and we need to make sure that we continue to invest in the clinical skill set of our staff as well. It also will reshape in terms of the alternative care pathways and the rollout of them as well. So the more that we do on that, the more our paramedic clinicians will be in people's home treating you at home, and that will be a different dynamic for them. And potentially in the future, there's some discussions going on about maybe a mobile health unit, which would be your ambulance that could maybe do other things like an ultrasound scan or an X-ray or something, but that's way in the future, and they're just starting discussions around that nationally. So I think what I would say to you is it would be nice not to be firefighting, if I may use that expression, in relation to it. It'd be nice to
We
have
use firefighting expression all the time.
it would be good to have the workforce stabilised and be in a very sound footing to move forward, and I think we're more or less getting to that point.
Just quickly following on from that, and it's just a quick question, then I'm going to move on to Dale. You'd mentioned there about the sickness level and 5% reduction, was that correct?
Yes.
Can you give what the percentage is at present?
It's in and around the 10%.
Okay, all right.
And 9.6 or something like that it is as of August. The interesting thing is that around 8% of it is long-term sickness absence. Yeah. So without appearing ageist and knowing I'm in that bracket myself, we are, the workforce is getting older. We don't have turnover. So what we find with long-term absence is that it responds well to medical intervention, occupational health, all those sorts of things to try and work through it. And there's only about 2 to 2.5% is the short-term absence, which is the part of the absence that you might consider that management of it might start to reduce it. But we do have an issue. Our highest reason for absence is musculoskeletal. And followed by stress, as you're probably aware from some of the recent media attention. The musculoskeletal is a case in point. We're doing everything we can to make sure that our technology is right in that lifting aids, that the training and all that supports that for our staff is in place. And we have, over the last 2 years, started a fast-track physio service, which is going very well. For our staff who have musculoskeletal type injuries. And on the stress side of the house, it is a difficult job. We're involved in some very traumatic cases, so our staff do a wonderful job in those situations. And again, we need to support them in relation to the stress that might entail. Now, it's all not work-related stress. There will be depression, will be part of that, and also, should I say, the normal stresses of life, like divorce and death, etc., will account for a portion of that as well. But it's important that we prioritise that and have the support systems in place. And we do have counselling services available to our staff in that as well.
Okay, that's good. A few more, but I'll maybe come in if other members don't cover it. Dale, if I could just move on to yourself. And I know we've talked on previous occasions as well, and I know from even sitting in the last mandate, we didn't get a lot of bother, let's say. It wasn't one of the services that we had to continually monitor to do with X, Y and Z. Our service just continued, got on with the job, like the ambulance service, just continued to do their job. But I know you were under extreme pressures to do with the modernisation of the service, and I know you mentioned there about your retained firefighters, and I know because where I live as well, that's what we rely on in the area that I live, is the retained firefighters. So it's just, and I know that there are issues, and you've mentioned difficulties about retaining those retained firefighters as well. So it's just, again, just that your challenges looking ahead, and I know there are many challenges through the remodernisation and through budgets and through cuts and everything else, and yet you have all managed to keep going because you have a job to do, and that's it. And that I know it's the same in the ambulance service. That's how you look at things. I have a job to do. I'm going to continue doing it. So it's just to look a bit more at your challenges and what you feel about that, and maybe talk a little bit more about the co-responding and how you see that, how that's going to work out. I know we've spoke about it privately, but it would be good to let others, the public know how that's going to work. That sounds like a really exciting way of working as well. So I'll start off with those. I've got my tiny things.
No problems. Well, Gary will talk more about the correspondence stuff for me. What I'll start off by saying is you're right. We face a lot of challenges. Budgets are difficult, and our budget's reduced significantly over the last few years. We're doing everything we can to modernise and change what we do to do that better, so we make the best use of everything that we have, and that's important. What I would say is despite everything, no matter what happens, our people turn up and do a really good job. And you know, the public satisfaction rate that you see with the fire service is because of that, because our people carry on getting on with it, and I can't commend them highly enough. There are lots of challenges, particularly around the retained availability piece, because life has changed. You know, these are people who live in smaller towns. They're not so busy. We haven't got that many fire calls for them to go to, is the truth of it. So it turns out the development of that is that people tend to work away from where they live, and that makes them less available for us. And that's a demographic change. There's not much we can do, but it makes it much harder for us to get good retained people and to keep them. But I'll get Gary to talk about the garden system, which has been a real helpful tool for us, and Gary chairs our RDS steering group, which helps as well.
Okay, thank you, Chair. We have 984 retained personnel in the organisation. We have 68 fire stations, and of those, 59 stations have a retained complement. So some are retained stations with one fire engine, some are retained with two fire engines, but some of a combination of the first appliance would be old-time 24/7 crude, and the second would be retained. So out of those 984, historically our recruitment would have been based on establishment. So a two appliance retained station would have had 20 personnel, a one appliance station would have had 12 personnel, and we'd have just tried to manage those figures. However, to the reference that Dale talks about, different station areas, different challenges in different station areas. In rural areas, the availability was different, irrespective of what your establishment levels were. So in March 2014, we brought in an electronic availability system that allows for all of our retained staff to, through a mobile phone, text in and out on when I'm available, I'm not available. And there's two big benefits with that. The first benefit is from a dynamic mobilising point of view. As a service, we know in our command room now, in our regional control centre, exactly how many retained firefighters we have available right now at this very second. So if we need to mobilise in Ballyclare, let's say, we know how many firefighters we will be showing up, how many fire plants we will get out, and immediately, if we don't think we have enough, we can mobilise the right number of firefighters to resolve that incident effectively from neighbouring stations. But the second benefit of the system is, because it's collecting historic data around availability, it allows us to analyse that data to actually see now, based on availability as opposed to establishment, where we need to recruit. So we've taken a new targeted approach to retained recruitment. So we've run two recruitment processes recently, and as opposed to just looking and saying we'll bring stations up to 20 or up to 12, there's now some stations we might be putting up to 22, 23, because it's all about keeping people safe. It's all about getting appliances out the door of the fire stations, whereas other stations that maybe have 17 who have really good availability and they've good appliance response, we're not actually bringing those numbers. So we're using the 994 sort of creatively across the workforce. We piloted a new daytime only retained model. This is totally new for Northern Ireland Fire and Rescue Service. We find that in most places we don't have difficulties at nights with firefighters being available and retained, and weekends sometimes can be more difficulty. But the big problem is Monday to Friday 9 to 5. It's those days when somebody's primary occupation is taking them out of the local town, and we used to recruit for firefighters to give 120 hours availability. Now 120 hours availability is a big ask. You know, it is a big ask, and rather than try and get new firefighters to come in at 120 hours and tie them into weekdays, we come up with this new model where it would be daytime only contracts. So about 15 of our stations, we have now recruited 2 people specifically that will come in, will be available Monday to Friday, sort of 8 to 6. We've brought them in, we've trained them, they're now on the run, and we've carried out an analysis since we put them in the stations, and availability in those stations have improved. We're currently recruiting for 15 or 16 stations currently, and we're bringing 47 retained firefighters in now as well. Will bring us up to about 980 something out of the 994. But again, that's all targeted, so it's a better return now with regard to where we're putting our resources to maximise appliance availability.
Okay, it's certainly much more positive than I remember other briefing sessions to do with workforce, and so that sounds like it definitely is positive and moving ahead. Just very quickly before I bring members in, I keep saying this, I know with the budgets some things are are difficult, and we're looking at sort of the education programme, and I think you'd said, was it down 20%, was that your school visits and etc. and things like that, which I think is vitally important, that we educate our children on the issues and the work that you do. And you'll also know, because I've spoken to you in the past about this, is the LIFE programme. I know you have your cadet programme as well, which is brilliant and really good. We're encouraged by that. But the LIFE programme, I've attended a few of the pass-off sort of parades of the LIFE programme in my station in Glengormley. In fact, my son took part in one of them many years ago, and you know of that also. And I find, I know for him and his peers that took part in that, it was a very valued programme that made them actually feel very part of their community as well, and and taking ownership for the area that they lived in. So I just if you want to briefly, do you see any cuts in that type of thing, or any further cuts rather in those sort of community and education programmes?
Well, we're actually in the process of reviewing all of our youth education programmes at the moment, and we really appreciate the value of LIFE. We think it's a fantastic programme, and well, I've had nothing but praise. I've never had somebody come to me and say that wasn't a great job. Everybody has been involved has said it's fantastic. What we do have to do now is we have to focus our resources where the highest levels of risk are. And we know in terms of fire safety, the people who are most at risk are those who potentially, there's a sort of categories of them. This is why working closely with other health colleagues is so important to us. I know that if somebody has lifestyle issues, maybe alcoholic and drug users or whatever, they live alone in a remote location, over a certain age, those are the people that are most likely to be affected and be unsafe. So we have to concentrate our efforts very much on keeping those people safe, because they're the highest risk. Having said that, there's real benefits to be had from youth education, really strong benefits, and we've seen some evaluation of that. It's difficult to do. It's very difficult to turn that into pounds, shillings and pence, but some evaluation we've seen has been really, really good. And from our own point of view, even getting young people to understand about what we do and not see us as a threat to them or having fun, and it's reduced attacks on firefighters. I mean, attacks on firefighters used to be something that it was just commonplace. It's actually very much the exception these days, which is a really positive step for us. So we really value that process. We want to do as much of that as we can. We're in the process of reviewing everything that we do to try and find the most efficient and effective way of doing that. We've signed up to work with the Prince's Trust. We've had some great experiences with them over the past. We've run a few team programmes and some of their other interventions with them, and we'll continue to do that. And we'll continue to look for other opportunities, and probably the biggest opportunities are really around partnership, because I can't afford to fund LIFE programmes anymore, but there are people out there who probably can. And I think we need to take a more sort of grown-up approach to things like sponsorship and getting support from other organisations to hopefully help us do those sort of things, because there is a real benefit to the community.
Thank you. Okay, I'm going to bring members in now. Can I apologise? I maybe spoke a little longer than I intended to and asked a few too many questions, but there was some information I had in my head I wanted to know. I still have some left, but hopefully the other members will cover that. First is Ian.
Thank you very much, Chair. And I want to say, first of all, thanks for your presentation this morning from both services. It was absolutely nice to have you here. And on a personal note, I'd like to thank both services, for the magnificent level of service that they provide, to the people all over the north. So thank you for that. My question is is to if you could brief or update the committee, as to regards to the air ambulance. When can they expect it to be up and running, and if there's any agreements already in place for cross-border cooperation?
That's okay. Nice. Question. Air ambulance.
Air ambulance. At this point in time, we've been working with all the stakeholders in relation to getting the memorandum of understanding together, and as to how we would go forward on it. The charity have obviously been appointed as at this point, and I think the Minister has asked for some questions of the CMO, and we're awaiting the response to that before we step forward on it. So I can't actually go into any real detail in relation to that, other than we're at the table. It's a very big priority for us, and we're moving it along as quickly as we can. And I think once the memorandum of understanding, our medical director is actually leading that on behalf of the trust, and he's working with the charity, with Annie, the aviation authority people, and with the Department of Health and our commissioners on that. So we're very keen to get that moved on, but at this point in time we're not at the situation of actually having it finalised.
On the news, I believe there recently, there was reports, of I believe of 700,000 or 800,000, to provide a landing pad on the top of the Royal, I believe, right? Is there not a facility on the ground which would be much more cheaper to land a helicopter than to reinforce and go to that extreme?
Okay, Mr. Bryan on that one.
I suppose in the past we have. That's how we did business when we had the support of other aircraft, and that's an ambulance, an ordinary accident emergency ambulance met the aircraft and transferred to hospital. However, for the type of calls that this aircraft would carry, they're time critical, and it'd be a much better experience for the patient and improve outcomes if they were to be able to land close to the hospital. The issue of the landing pad at the Royal, and I could stand to be corrected in this, I believe is an issue for the estates people who commissioned the hospital, and wasn't something that was taken account for in this project. This is mostly about commissioning the actual helicopter itself. So, but I believe it has been addressed, and as Rushin said, there's still a lot of questions that have to be answered, and I believe that may be one of them.
And just for a matter of interest, when you talk about an air ambulance, how many people would you expect to carry on that ambulance? If in the situation, that there was multiple serious injuries.
In terms of the capacity to carry?
Yeah.
Again, I'm not an expert in terms of what craft has been specified. That is dealt with through the Association of Air Ambulances. But normal situations, it would be one patient. I'm not sure, and I think if you increase the capacity, then you get into issues of how long it can fly for, whether it can get into day, night, and there are lots of permutations there. But I believe it's one.
I think as that progresses, that will come through this committee, that they'll start to see the specifics then of what and the memorandum of understanding,
yes,
and whether it's going to be fit
yes.
for purpose, because we need it to be fit for purpose. A lot of money being spent, so I think it's a good question, but we'll be addressing that as we go along. So.
Okay, thank you, Chair. And if I could ask the fire service one, please. Could you outline any difficulties in terms of access to additional support or equipment the fire service faces due to the natural barrier between here and Britain? And is there cross-border? You mentioned cross-border cooperation. Could you tell us if there's any agreements in place, for cooperation across the border? Thank you.
Okay, thank you. In terms of the access to equipment and vehicles and that sort of stuff, what we try to do is we try to join up as much as we can with UK Fire and Rescue Services, particularly around procurement things. And you mentioned the fact that we're procuring our command and control system along with Scotland, because when you do that, you join up, you get obviously benefits of scale, and it reduces the cost of taking things forward. So in terms of our procurement, as much as we possibly can, we're doing everything we can to make sure that we get the best value by going with the biggest group of people, because effectively most fire and rescue services are buying the same sort of things. There might be a slight difference in some of the equipment and the vehicles we use, but they're more or less the same. So we're doing everything we can. Now there's work going on. A lady called Anne Millington, who's the Chief of Kent, is working on a national procurement group, and we're included in those conversations. So I'm hoping that what will come out of that is an even more effective way for us to procure equipment and vehicles and anything else that we need, and save a lot of money and save a lot of time and bureaucracy too. In terms of the cross-border stuff, we have a long-standing arrangement with Donegal in which we provide fire cover for part of their county. On a payment basis, they pay us for our services. And with the necklace counties, as we call them, what we have is we have arrangements in place. This is early work that I started a couple of years ago in relation to joint response, now particularly around road traffic collisions at the moment. And basically the setup we have is that if there's within a specified corridor along the border, if there's a road traffic collision, we both go. Because at the end of the day, what really matters is that the person who's stuck in the car gets attended as quickly as we can. So we don't mind if we get there and find that the machine from Cavan has got there before us and dealing with people, no issue. As long as we're both going and doing everything we can to make sure that people are safe. Those arrangements are all of the counties now, apart from Cavan. Cavan just needs to be finished off in terms of the MOU, but with the rest of the counties we have arrangements in place. We also have an arrangement whereby I would meet with all of the chiefs from the across the border on a regular basis, a couple of times a year. And basically we look at issues that we share and we look for opportunities to do things together. We ran a very successful project a couple of years ago called Drive and Change, which was all about, it was a range of things. It was about road safety in the wider sense. So it was about training our people to a higher level of, and doing joint training with crews from across the border. We also did some very useful public relations work in relation to education stuff, got youth groups involved, and the project was managed by a fellow called Ian McQuitty, who done an excellent job of pulling everything together. And there was there was other things came out of it, things like a conference and joint learning, but probably the outworking about the long-term benefits of that is this these MOUs, which all now getting developed, are in place. So there's lots of good work going on between ourselves and all of the border counties.
Okay. Thanks very much. Thank you, Chair.
Ian, Trevor?
Thank you, Chair. Roisin, can I take you back maybe to the start of your presentation, in terms of recruitment and the difficulties you have with recruitment? I'm somewhat staggered by that, because there was questions, and I know I have asked questions over the last number of years about campaigns you actually had and you appointed people on temporary contracts.
Yes.
And then you went out to competition again. So can you tell me where the change came about here?
Okay. We had X amount of vacancies at one point, and we moved on to a workforce stability programme. So that was about 2 years ago. So what we put all our efforts into actually appointing and recruiting and appointing our paramedic workforce, our EMT workforce, and our patient care services workforce. The temporary staff that we normally would have would be to help, because a lot of our staff start as patient care services, and then when we advertise for a technician, a lot of them go into that, which leaves a vacancy, etc. So the temporary posts wouldn't be attached, the temporary recruitments wouldn't be attached to a permanent post. They will be to allow some capacity while people are going through training arrangements. So for example, we have some of our staff who perhaps won't be successful at getting through the next training element, and their job would be protected for them in the grade that they would have worked at substantially. So that would be the only time that we would recruit temporary staff. Would actually be for...
Can you tell me how much does it cost to train a paramedic?
I think I haven't got the details as we sit with the new programmes that are gone, but roughly I would say about 40,000. That's
40,000. Yeah. That's what was in my mind too from the question I asked. But I'm sure, maybe this is something that I can look back and write to you, this one, but I'm sure I have information going back over a number of years where people were employed and trained on temporary contracts for 40,000.
Paramedic and training.
For EMTs and paramedics.
EMTs. Paramedic and training would have been a 2-year training contract. And then they would have come out and applied for posts. And then we did have a situation...
sorry, can I stop you there? Why are they in a training programme and then applying for posts? Why are we not actually having the posts, substantive posts, training people and keeping them in employment?
Social work's the same. A lot of it's the same.
I know, but 2 wrongs don't make a right.
No, absolutely. And we have done that the second methodology as well. We've also done that at times as well. I guess it depends as to whether there's any vacancies at the tail end of the training programme.
Well, actually,
So
I mean, you're saying today there's 61 vacancies.
there's in our emergency medical technician,
Yes.
yes.
And there's been a trend within your department to train people and then let them go. So we'll spend £40,000 for this programme and then we'll actually ask them to apply for a job. Why not advertise a job? Sorry, let me finish my point. Why not advertise a job if there's a vacancy, bring the person in and train them. If they meet the standard, they stay, and if they don't, they go.
That, in essence, that is what we do. Now,
Sorry, I keep cutting in it. There were temporary contracts. They were not permanent contracts.
there were student contracts for the paramedic in training. What I know as we sit today, we had a situation about a year ago, I think, where some people weren't successful or were on a waiting list for a paramedic post and there was no post for them to go into. So they would have gone into permanent technician posts. What they've done now is apply for the next vacancies that came up whenever the paramedic post became available, and they're now either in a paramedic post or about to be appointed to a paramedic post. So we actually haven't lost any of the investment that we've put in. It's just at the end I suppose you have to, when you're planning for the training of paramedics or technicians, it's like, and obviously if paramedics go to the university at some point, as they are in other ambulance services nationally, you have to, there will be some attrition as well. So when you're deciding how many to bring into the training school, it's not always equating one-to-one to a vacancy either, because at times students will go off somewhere else. They maybe go and work in a different ambulance service, they'll maybe go and work somewhere else, or maybe go on and do a different type of degree like nursing or something on top of that. So it is complicated in the way it's done, but we are the only employer at this point in time of paramedics within Northern Ireland. So when we train them, we usually get to employ them at the end of the training.
Certainly my experience from my constituency, and I've met some of those people who've come through the programmes, weren't offered permanent jobs, but encouraged to reapply for another programme. But I'll leave it there. I don't want to labour the point. But in terms of those vacancies, and I mean, we're talking about the stress. Brian, I think it's you who's been in the media possibly a few times by defending the position. Is there any of the stress related to the fact that the pressure these people are working under and the fact that they can't get days off because of the vacancies that are actually in the service at the moment?
Well, I'll take the first point in that granting people leave requests is certainly a pressure for us. As any organisation, particularly at peak times, Christmas, New Year and summer periods, we are a 24/7 organisation, as you can appreciate. And what we do with people's leave, we break it into two big segments. We have everyone in the organisation and front line has rostered leave for winter time and has rostered leave for summertime. And we commit, no matter what's happening, they are given that leave. On top of that, they have an element of what we call casual leave. And casual leave is where if someone needs a day off for a wedding or a birthday or whatever, that's how they would use that leave. And when they apply for that leave through our resource centre, we endeavour to grant 100% off. But because of the exigencies of the service and the need to provide cover, that isn't always possible. So yes, some people don't get the leave that they request. Last year, because of, as you've identified, the associated stress and anxiety with that, we reviewed that process and we committed to granting each station 10% of applications for casual leave. So most of these leave requests were coming in at weekends. Our demand is greatest at weekends. Our need for cover is greatest at weekends. And though we have a relief tier, we do to support applications for leave, it doesn't support the demand. So we had to put in some sort of a control to enable safe service. And as a consequence of that, you're quite right. Some people were frustrated and annoyed with that, and whether that has attributed to increases in stress, I suppose each case will be viewed in its own merit. All I can say that it's a balance between efficiency. You've talked about recruitment. We can only recruit whole-time equivalents to the funding that we have. We have to ensure that everyone we recruit is used, so we can't have people used during the summertime and not have work for them during the winter because they're not needed on the rota. It's a very difficult and complex thing. All I can say to you is that, again, the capacity review that we're going to complete will look at the hours that we need, and when we need those hours over a 24/7 period, it'll look at the number of full-time equivalents that we require to support those hours. And again, we internally will look at the rotas and the rosters, and we've already brought in some innovative practice. We didn't have bank staff before this year. We've done that. We actually are very positive in terms of our family-friendly policies. That adds to the competition for people who get casual leave.
I would suggest you're not, where a paramedic I spoke to couldn't even get leave off to go to his uncle's funeral. So I wouldn't say that's necessarily family-friendly, where someone's lost, they only get one opportunity to attend a loved one's funeral, and they couldn't get leave off, and that was midweek, Brian. That wasn't a weekend, but they couldn't get the leave. And I mean, I've been in the A&E department on numerous occasions, and the stress these men and women work under within the ambulance service is horrendous. But you go out to the media and try and defend the party position in terms of your department, but you don't actually take into consideration of those who are actually in the frontline service.
Well, that's your opinion in the matter. I've given you my view on,
yeah.
on how
and that's
you
the opinion of the fire. That's the opinion of the staff who are actually working in the service as well. And I think that adds to the number of people who actually. I mean, I was looking in statistics. You've set targets in terms of sickness levels. You're way beyond that, and some of that is fed into the fact that how the people are actually treated who work for you. Thanks, Chair.
Okay, thank you, Trevor. Gary.
Thanks, Chair, and can I thank you for coming on today. I just want to go back, and I think it was Gary that answered it in relation to the pilot scheme at Lurgan. Could you tell me, maybe you did mention I missed it, but how long is that pilot scheme going to last, first of all? And can you give us examples of possibly where you are working or could work with the ambulance services and other services as well to co-respond? Because I did read one particular story recently where the Fire and Rescue Service rescued a gentleman, I think it was in Balik, and provided the first aid cover until the ambulance service did arrive. So that sort of work is very useful. Obviously, it's life-saving as well. But could you give us maybe an update on that?
Well, look, firstly I'll deal with the co-responding. So the co-responding is a medical emergency response pilot. It's for 6 months. This is nothing new in the UK Fire and Rescue Service. It's widespread across the water, but this is a first for Northern Ireland. The National Joint Council have approved these pilots in England. I think there's about 40 schemes currently running. And we approached each other to see if we could set up a pilot scheme. Now, some of the issues you would look at firstly to add value is that it would need firstly to be, for us, it need to be zero cost, so it can't be an additional cost. Obviously, if we initially went out to retain stations every time, some retain stations in England went from 60 calls to 600 calls per annum, so that would be a big increase in revenue costs. So I identified our whole-time stations where we have personnel that are already on those stations 24/7, they're already being paid, and looking at rural locations where we could hopefully work in partnership with the ambulance service and add value. And so we identified several stations of which we agreed we would pilot first in Lurgan. So it's been going from it's 11 days today. They've done 19 incidents. Morale's good in the station. The two organisations have been working well on the ground. I think about 50% of the calls fire service have got there just before the ambulance service. The other half of the calls, the ambulance service were there first. Good partnership working on the ground and good feedback coming back from the station. What will happen is the pilot will run its course, the 6 months, and then at the end we'll carry out a review of how the pilot performed, and then decide whether we will move forward on a permanent basis with the pilot in Lurgan, or is there an opportunity to expand that throughout the province. I think it's a good example of, the outcomes-based accountability piece in the draft programme for government, where we're providing better outcomes for the community that we serve at no extra cost through partnership working of public sector organisations. And I think the other point you raised about rescuing people. Like, if anybody dials 999, we just go out the door. So whether the police are calling us, whether it's community search and rescue, we go to a range of incidents now. We're no longer a fire and rescue service. There's a wide range of call incidents that we go to, particularly around search and rescue, and our urban search and rescue team would go often to people that are trapped, even people that are missing.
Okay, well, that's very encouraging to hear, and hopefully we'll maybe hear back in 6 months' time to see exactly how that goes. And I think it's encouraging that we're, number one, falling into line maybe with the rest of the UK, but not just for the sake of it, on the basis of best practice. So I think that's very good. Just to move on, I suppose again it's for both of the services in a sense that we always hear, unfortunately, of attacks on those that are responding to emergency calls. I noticed from the report that the fire service have gave that their attacks on them are down 46% on last year, or attacks on the firefighters and the appliances, which I think is a good thing, obviously, but we need to try and eradicate it totally. Hoax calls are down 20% as well, but unfortunately for the ambulance service, you're seeing, from what I believe, a 5-year high on attacks on your ambulance personnel. So I think maybe the message that we're getting here is there something that the fire and rescue service are doing that the ambulance service isn't doing in terms of education, making people aware of why you shouldn't. It's obvious to most of us, but unfortunately there's a small minority who see fit to attack our emergency services. So is there anything maybe we could do to try and address that situation?
Okay, I think in the past we have done some collaborative work on that, and you'd have seen some of the adverts on TV, etc., that we've worked together on. We have a very small resource within the ambulance service that focuses on community education, particularly around primary schools and other events, to try and talk to kids and teenagers, young adults, around the consequence of violence to staff, etc. We also have a subgroup of our Health and Safety Committee that's a partnership group with trade unions and management side, who actually focus on the zero tolerance bit of work. I think what we find is that the violence to staff is quite sporadic, and it's difficult to plan for and difficult to it's difficult to plan for and to develop the strategy about. The zero tolerance is the zero tolerance, and our staff would be trained in relation to carrying out risk assessments around calming and diffuse and about how to operate in those environments to try and lessen the risk on themselves. But unfortunately, we do experience it, and it's about the safe practice of our staff in that regard and supporting them in that. We've been asked this week actually to do some media work. I think it's tomorrow. Brian's been interviewed on this very point, and we're trying to get some staff who have went under attack to actually start to showcase their story, what it meant to them, what it meant to their families, etc., etc. And hopefully that will help get the message out there to the public as well. But it is a very difficult a concept or a piece of work to move forward on, but we do prioritise it, absolutely. Perhaps
I can add to that. What we do, similarly, we have an education programme that goes out to primary 5 children. We find that to be of huge value. Now, again, that's one of the things that comes under pressure as our budgets tighten. But when we have it's a series of characters. They're cartoon characters, and the firefighters talk about them, and they educate the children in relation to different aspects of safety. But we talk about attacks on firefighters, but we don't actually talk, we talk about attacks on everybody. When we try to explain to young people the consequences of, what happens if you break the windscreen on that fire engine or that ambulance or that police car. And what does that mean when those vehicles are not available then, and that sort of stuff. So that's what we try and do and get that across at an early age. We have a hugely improved picture from where we were. When I was a young firefighter, time without number. I had to dodge bricks and all sorts of stuff being thrown at me because we were seen as part of the establishment, and it was fair game, and people didn't see any problem with that. So things have hugely improved. I would accept that there's plenty of room for more improvement, and the recent sort of collaboration work that we've sort of entered into with NIAS and with the rest of the health as a whole, I think provides an opportunity for us to try and cement that and get that message out there a bit further. Because what we've learned is that young people do learn. They do understand that, well, actually, maybe I shouldn't throw that stone then, because that windscreen costs £700, and that's £700 we don't have then to pay for retain firefighters or what have you.
Yeah. No, I agree with you, and that's an example of where cooperation between the two services does benefit. And obviously, and you refer to budgets for this type of education, but I think ultimately it's a small amount of money which will have huge savings in the long run, not only for protecting the staff but protecting the appliances as well. Chair, I want to just go on to another issue that I wanted to raise in relation to, again, unfortunately, it's the ambulance service I'm referring to in regard to response times. The constituency that I represent in Foyle consists of quite a rural constituency. Now, we quite often, it's not really a fault sometimes of the drivers, but trying to find addresses and get locations. Now, it was my understanding there's a new system it's either in place or it's going to be in place within the ambulances, which will allow quicker, obviously it'll end in quicker responses. But for ourselves, as a council, when I was on the council, we tried to encourage people to put numbers on their properties, which is important. But whenever you're out in a rural constituency, sometimes numbers mean nothing. Sometimes you have to try and get there by other means, coordinations or whatever. So could you give us an update maybe on that?
Okay, I'll ask Brian to update that.
Yes, well, as the Chief Executive said in her presentation, it's very important that we explore all technologies and see if it can benefit our service, and we certainly have done that. We did install mobile data terminals on the ambulances. So previous days, a call came in, it was passed by radio to the crew. It depended on local knowledge. Now those days are gone, thankfully. The call is passed electronically. It goes on to almost like an iPad on the dashboard. It'll identify the location of the incident and any details that we have in relation to it. And when the call comes in, we can actually plot it from a gazetteer on the control room, and we can track the ambulance on its way to the call. And if need be, we can give directions by radio into it. And in fact, that mobile data technology that I've spoken about is just up for refresh, and we've just had our business case approved for that. So hopefully we'll see the benefits of enhanced technology over the last 5 years as we bring in the new system.
Well, I think that's welcome, and as I say, it'll certainly benefit the waiting times. In terms of the Fire and Rescue Service, there was an audit done fairly recently, and you mentioned one of the issues being your governance, and you're trying to restructure all of that. There was quite a few, and I won't go into it because it's in the report and everybody can read it. There were quite a few concerns raised by this independent audit in relation to governance and in relation to financial and expenses and things like that. How far have you gone to address those recommendations?
We have a series of recommendations that over recent years that we're in the process of dealing with to sort of get an idea of where we were. Sort of 18 months ago, we had something like 690 odd recommendations. What we've done is we've pulled them all into a series of business improvement plans, and some of these go way back a couple of years, and they're from external reports and our own internal audit and various things. We've pulled them into a series of business improvement plans, and we're working our way through them. Now, we've made significant progress in that now. Funny meeting with the Permanent Secretary recently just to sort of outline how far we've got, and it's important for us because these things have been hanging around for a while now. We need to get them cleared up. But I mean, so to give an idea of the progress we've made. A short while ago, we were sitting with something like 690 outstanding recommendations against us from various, sources. By the end of this financial year, that will be less than 100, and 74 of those will be cleared up within the next financial year. So we've made, I believe, we've made significant progress, and we recognise the importance of that, and that we have to keep the pressure on and keep things moving. But we're in a different place. We've turned a corner in relation to that.
Mm-hmm. Just the last comment, just to sometimes we can all be very critical. I just want to put on record, obviously, our appreciation as well, and thanks for the work that you do. Obviously, we're here sometimes to try and hold people to account, but we do genuinely appreciate the work that you do. Thank you.
Thank you.
Thank you, Gary. Joanne?
Thank you, Chair. Thank you for your presentation. And can I just reiterate what Gary has said? Your staff do an amazing job 24 hours a day, and we're eternally grateful for that. First question is to you, Rushing, and you paint a positive message going forward. So have you every confidence that the crewing crisis you've experienced is behind you? Because following on from Trevor, I think Trevor made a few very valid points about morale and staff feeling, covering shifts and getting valuable time off is very, very difficult, and certainly we all have constituents who have approached us telling us this very issue. Because recently I asked the Minister on many occasions if the ambulance service fell short of a full complement of staff, and she wasn't able to point me to an answer of when that has happened. So can you enlighten us as to when that has happened?
I think, as the presentation shows, that we do have 61 vacancies in our technician workforce at this point in time. So I think it's slightly complicated in terms of you're looking at, does that equate to dropped shifts? And does that mean that, the public aren't...
You're bound to have data and information as to when you didn't have the full complement of staff. Surely you have records to show when that happened, when that occurred, on how many occasions. I'm trying to tease out when that's happened.
Yes. If you're asking in straight staff terms, we have 61 technician vacancies as we sit today.
But occasions when you didn't have the full complement, when existing staff felt they're under extreme pressure and they have been trying to fulfil those duties.
Okay, so for example, those duties would be filled at this point in time by staff doing overtime. So that is the situation that you're describing, I suspect. But in saying that, I would have to say that's a big improvement from where we were 2 years ago. And we would hope, with the 2 cohorts that are coming in this year, to be in a position where we're basically at full complement. By this time next year, would be assuming we'll be at full complement.
I'm just trying to tease out occasions when you haven't had full complement. Maybe my second part of the question, maybe help you answer it first, because we're seeing voluntary crews and private ambulances picking up the slack when you don't have the manpower to fulfil that. So I'm trying to tease out, as Trevor has maybe touched on earlier, on many occasions you didn't have the full complement of staff, and when the voluntary crews and the private ambulances have picked up the slack.
So that in essence is when we would drop cover.
Yeah.
So I'll pass it over to Brian.
Okay, and you are correct in your assessment. There have been many occasions when we haven't been 100% compliant with the hours, contracted hours, and that has been as a consequence of the vacancies that we carry. It's been as a consequence of sickness absence levels, and there are many reasons, as in any organisation, where you wouldn't have the full complement of staff on any shift. And the normal process,
sorry, Brian, you would have the data and the information.
We have the data, and
could you maybe furnish me
absolutely,
with
yeah. We have
and share it with the committee. I think we're all trying to tease, because we're hearing from crew that feel under immense pressure. It would be good for us as a committee to know how many occasions that has happened.
Okay, and we have a resource centre whereby, in that centre, it's a small team of a few people, and their job is they identify the vacant shifts that we know that are coming up. They work with staff, inviting them to work the overtime, but they also monitor times when we aren't able to cover the shift, and we have that information. And I suppose...
Is this still a regular occurrence, or has that been...
It still happens, absolutely. We have people who, tonight may ring at the last moment, and because of sickness or caring arrangements aren't able to do their shift, and therefore we drop that shift at the weekend. To go back to Mr. Clark's comment, over the summertime at weekends, when people are requesting leave and all of that, we had a very high incidence, and I'm not going to hide behind it, of lack of compliance with cover. When I say high, we would normally average around 80%. Come September, we were up on 95%. So it is a seasonal thing, as I said in response to Mr. Clark's question. So what happens then, if the only way of eradicating it completely is basically if you over-establish against the hours of cover that you are contracted to provide. We are constrained.
And is that what you plan to do? Because Roisin said in her opening remarks that she hopes to be in a strong position with regard to workforce by the end of this year.
In terms of vacancy covered, that's not necessarily the same as shifts dropped.
The two tie in. Obviously, you have the vacancies and you don't have the manpower to cover the shifts, so they're interlinked.
Yes, yeah.
Okay,
But
so
there's, I suppose there's reasons for overtime that aren't equated to vacancies. For example, if there was a long ambulance journey from one hospital to another and it was at the end of somebody's shift, you know, they may
I understand.
have overtime.
I'm just concerned
So it's,
of great potential consequences if you don't have the cover and the pressure that those
Absolutely.
crews are under. If, as
Yes.
Trevor has articulated earlier, if you don't have the manpower and the cover.
Can I just say it is complex, and I think what I'm very clear on is that we will be in a position by this time next year where a better position we've been in for some years in terms of the amount of vacancies that we'll be holding in our frontline workforce. However, I have also mentioned the capacity issues we have, and they'll still be there. And whether and the activity increases, for example, that 23% activity increase in our frontline category A life-threatening piece of the work, that those sorts of capacity issues will still be there. So there will still be a requirement for overtime at times. There will still be a requirement for staff to take time off work at short notice. There will still be a requirement for sickness absence, etc. that will be in that. So absolutely, we would hope to get to a position of not being in any crisis in relation to vacancies and to have more or less a full complement there.
Okay.
But there's still
Brian,
the other
your
dynamics.
point again, I'm concerned about cover, so that's still occurring currently, the lack of cover and staff working under.
there are occasions when we have drop shifts, and
you'll
those-
furnish the committee with that in writing?
we can provide you with detail on that.
Okay.
But I will say that two things. First of all, we, as the Chief Executive said, are committed to ensuring that we fill all of our vacancies. Having done that, drop shifts then are a consequence of other factors such as sickness and things that are unplanned, and and also seasonal variation. The seasonal variation, we're starting to look at bringing in people on short-term contracts, part-time contracts, to address that. So we are getting to a better position, and I have to acknowledge, first of all, my gratitude for staff who volunteered to work the overtime, because that indeed helps, and also to the staff who do work the shifts when some of their colleagues aren't able to attend work, and the extra work that they commit to undertake.
We all have gratitude for staff, but they're under amazing pressure. Right, I can ask you then about, you touched on defibrillators. Can I just ask if an organisation raises money, voluntary, to bring different defibrillators into town centres? I know there's quite a lot are doing this, and they're doing amazing work raising funds for that. Thinking the Lions Club and Banbridge, among others, locally. Can the ambulance service provide appropriate training for that, or how do you connect with that? Because there's so many people out there raising money, doing a fantastic job to bring them, but obviously they need the training to support that. What do you do? Can you do that, or are you doing that, or?
We don't provide that service. That would fall under the community resuscitation strategy, which it's just been launched, and there's work ongoing in relation to how communities would be supported in relation to that. So we don't actively provide that service. We are more interested in coordinating the response. So we're very keen that communities who do secure an AED, let us know where that ED is,
Okay.
So that we know we can put it on our system, and then if a call comes in, we can direct the caller.
So those voluntary organisations and people in the community that are providing those, where do they look at for getting the training then?
There are various organisations, both commercial and voluntary, who will provide that service.
Okay,
But it's not part of the service. We currently don't provide it. That's not to say that there are opportunities there that may present where we could, subject to support.
Okay, finally, just before we go on to the fire and rescue, 8-minute response hasn't met the target since 2011. Particularly, I think Gary touched on rural areas. It's quite alarming too. Dale? Thank you for your briefing, Gary. You and Gary as well is very interesting. I'm interested in focusing initially on your shift patterns and crewing framework, and again this has been touched on briefly. You say in your briefing that they will allow you to make better use of your responses, but is it not true that there's been a concern amongst the public also and frontline officers, culminating in our assembly motion that we had back in the chamber in January? The reason I'm asking this is, whilst moving the motion, I highlighted, Dale, your letter of December 2015 to the then Health Minister, highlighting your concerns and, in your words, of the devastating impact of a budget reduction of 5 or 10% in 2016-2017, which we're currently in, on how this could lead to, your words, unacceptable risk levels. So can you maybe outline what has changed in the 9 months since you wrote that letter?
Okay, well, first of all, the letter was around looking at 5 and 10% reductions in our budget. That wasn't what was levied against us, much less than that, we were glad to see. And so to some extent that has helped enormously. Now, having said that, it's still tight. We got a fairly small budget reduction this year, 1.5%. But that on top of the previous couple of years where we had budget reductions as well, those all accumulate and it gets progressively more difficult. I suppose what will change and what will make things more manageable, we recognise, we've said, you're quite right putting my letter, the impact of that big cut quickly like that would have been very difficult for us to deal with, really, really difficult, and we would have struggled to provide the service that we have to provide. What's different going forward is that we seek to do much better with the resources that we have. Now, that's still not going to mean that we can afford to cut away for instance, with the fact that I mentioned that we need to recruit next year is one of the discussions we're having with the department at the moment, is around how we get some support for that, because recruits cost money to employ, but they don't actually start reducing the overtime bill until you get them onto the fire engine, so there's a pressure there that will come along with that too. But our hope in terms of managing our budget much better really sort of revolves around more innovative approaches to our crewing framework and our shift systems. And I could try and tell you a lot more about that, but Gary's been doing all the work on it, so I'm going to get him to
it's just some interest, because if you recall at the time the Fire Brigades Union said that cuts of this magnitude proposed would see potential station closures, station downgrades and firefighters' numbers slashed. That was quite a chilling assessment, so I'm just interested in were they right or where we are now.
We didn't have the cuts that were proposed, so that's why it didn't happen.
Before I let Gary talk a little bit more about the shift systems, what I'll say is we haven't closed any stations. We've been able to manage now. It's getting more and more difficult to do that. We still have the same number of fire engines available now as we had beforehand. And that's because of some of the steps. What I also will say is that our proposals going forward, actually, despite the difficulties we're facing, is to increase the level of cover in 4 stations in Northern Ireland. And that's by a much more imaginative and innovative approach. I'll say Gary will elaborate a little bit more on that, because he'll do much better than me.
I think probably where a wee bit of confusion maybe entered was we were already doing work around the new crewing framework. So the integrated risk management plan is all about making sure you have the right resources in the right place at the right time. We had developed a new risk assessment methodology. We have 67 defined station areas. We had assessed risk in those 67 station areas. We looked at our resource allocation throughout those 67 station areas, and then looked at proposing a new model. So we were looking at how to have the right resources, right place, right time, how to be more efficient, how to crew better, how to utilise people when they're on watches, where we change how they do their training, they change how they get their leave, so they don't need as many people on, but we still provide the same level of service to the public, because public safety and firefighter safety is still our #1 priority. So that work was already going on, but it was going on in a risk-based and an evidence-based approach. It wasn't budget-driven. Dale's letter, which was entirely correct, of the 5 and 10%, would have been devastating and detrimental to our service delivery. However, the work that was going on was planned, it was risk-based, and there was maybe just a bit of confusion in around some of the work that we were doing that was the right thing to do, and risk-based was getting mixed up in the cuts conversation.
Because it was quite a hard-hitting letter.
Yeah.
Finally, if I may, and I know Gary has touched on this, the work undertaken in the ambulance service with fire crews to provide first response, particularly in Lurgan, in my own constituency. The pilot scheme in Lurgan 11 days ago. Can I ask just what training is provided to officers who provide it? I think you've touched on why Lurgan was chosen, you touched on that earlier. And who will decide on when the fire service would respond, first response, rather than the ambulance service? I'd just like to tease that out a bit more, and the joint ultimate aim of the 6 months project.
Okay, again, I'll get Gary to elaborate mostly on this, because this has been a feature of his work. What I will say is that there'll never be a situation where we respond instead of the ambulance service. It's co-response, so we both go together.
Okay.
It's to support the ambulance services, not instead of. So that's an important point to just tease out. But again, Gary has led on most of this work, so I'll get him to elaborate more.
Yeah, so to touch on the training, all the personnel that are used in the pilot, all the whole-time staff in Lurgan Fire Station receive what we call FPOS-I training, which is first person on scene intermediate. So that's a full week's training, and we done that over 2 separate weeks where we trained up the whole station effectively to be able to respond. So that's the training. It's a contract that we have as an organisation. Our road traffic collision strategy and the trauma care and the medical care that we have to give sometimes when we arrive first, even at a road traffic collision. We have already determined as a service that we want our staff to be trained first person on scene intermediate. So because we have that contract, it fitted well across with regard to training up the whole of Lurgan Station, the whole time complement there, to be able to respond to the medical emergencies. Again, what Dale said, it's not, in a sense, it is a community first responder. Again, that name can cause some confusion because it's not you're going on your own. It's always co-responding. Both services are going, and it's just to try and bring that added value where you can maybe get there quicker, because it can be minutes and even seconds that'll make the difference in relation to somebody's survival rate.
And after the 6 month project, is it going to be rolled out or assessed? Or?
Well, I think we will do that as both services. We will come together at the end of 6 months and we'll do it. We're capturing the data. Every incident is being captured by our command room. We're capturing the details. All the messages are passing back. We will carry out probably a midpoint review, but at the end we will determine whether it's something that we want to take forward. And look, we've got a memorandum of understanding already set up. There's no doubt that that's in draft form. We will tease out issues through the actual operation of the pilot, and then determine whether we will continue with it and whether it should be maybe expanded throughout the service. But that will be a decision now. I'll tell you what it's
great team in Lurgan Station to thank you.
Thank you.
Thank you, Joanne. Robbie?
Okay, thank you. Delighted to get in now.
Would you be in first?
Now, obviously some of my focus will be the fire service, you'll be glad to know, but I will start off with you guys. And I'll declare my sort of interest and biases. I was in the fire service up until very recently.
Attacks have gone down.
Attacks have gone down, but the performance is like really. Okay, so with regard to, I'm really interested. I'm glad that both organisations are here together. It's the way it should be. I'm stating that now because there's something coming at the end for you. Okay, with regard to that. So the first and most important thing for any frontline service is going to be patience, the clients, or whatever you go. And I'm a wee bit concerned in and around the performance. Guy touched on it, and Joanne picked it up. So in Belfast, cracking response times, you're hitting that 8 minutes and it's brilliant. But the worrying thing for me is they also get to hospital quicker. So in the rural areas, the reality is we're not hitting the response time, and it's longer to get to hospital, because there's a level of care you can expect and will receive, and it's excellent. It's top-notch service. I've worked with paramedics many times, EMTs. It's fantastic, something to be very proud of. But it's a poor relation. And I understand the business side of it. So I just want to know, is there anything specific you're looking at to change that? And the thing that worried me was that, and the fire service will get the same question, I'm really keen on response times. You talked about triage and the call handling. Again, we've got first-rate call handlers in both services. And triage is important for avoiding the nuisance calls and that type of thing. Patient-centred care has to be at the core of what we all do. So what are you specifically going to do to improve those performance times, the attendance times and actual attendance in those places where actually I think the risk is greater?
Okay, I'm going to pass over to Brian for this, but I think I would link it very much to making sure that the targets reflect good patient outcomes and good measurement of patient outcomes within our targets. But I'll pass over to Brian to take the answer.
The simple answer is that change the target and make it a more meaningful target. So currently we have a situation where when a call comes in, we categorise it as red, amber or green, and red calls are potentially life-threatening calls, where we would send an ambulance or an RRV to deploy within 8 minutes. And you're quite right, even the 72.5% target is an inbuilt inherent inequity in terms of, the service.
Absolutely.
And you're also quite right that Belfast does get a very good service, because not only are they closer to hospitals and have quicker turnaround time, but also a lot of the rural ambulances coming into the Belfast area have patients, and when they're leaving the area and a call comes in and their closest available, we will send it. So that's where we are. But the difficulty is we're chasing the 8-minute target, and realistically, not all of the patients that we arrive at require an 8-minute response. So, as the Chief Executive said, we want to review currently of the total 999 calls that we triage, 38% of them are Category A targets. And we want to review that, and we want to put in place, your point is a valid one, there should be time critical targets. So for cardiac arrest, people with respiratory, not breathing, choking, drowning, there are certain specific calls that we need to get to in 8 minutes or less. And we need to build a system that will deliver on that. But that would reduce the number of Category A responses from 38 potentially down to 10% of demand. And that means then we could look at more realistic targets for the other conditions, such as chest pain and trauma calls and those types of calls, whereby we could, and this is where we need people like you to help us support and bring this in, where we could have extended response times, but within reason. So, for example, Wales and Scotland and services in England have started work on this, because they've realised that a target that was set in 1974 has outlived and is outdated and isn't what the system needs. So critical patients require critical response times, and that should be 100% across Northern Ireland. And then we should reduce, we haven't done that, that reduces the pressure on the system and allows us to put in more meaningful targets, outcome-based targets, as the Chief Executive said, for some other specific clinical conditions. A good example of where we have achieved without inequity would be primary PCI. We have a centre in the Royal, we have a centre in Altlingalvin. And our obligation when we worked with the teams in setting that up is that we would have a patient in there within an hour. And we've achieved 100% in that, no matter where they live in Northern Ireland. That's a good example of a shift in designing the service around the needs of the patient rather than imposing an impossible target. And to go back to the stress issue for staff, it's, they are working harder, seeing more patients every day, spending longer with patients, spending time stuck in ED departments when they're not getting their breaks, but also, to constantly chase a target which is not achievable is very demotivating. And we really think that this piece of work in reviewing the capacity that we have is important. And the next stage then is moving on to making it more clinically focused and time appropriate.
I thank you. I welcome your remarks, but I have to say I'll be keeping a close eye on it for both services, because the buzzwords are great, and outcomes, and everybody's into outcomes, and that's great. And the programme for government's all about outcomes. Actually, it's only about people, and actually, it's only about the people care about is getting that care at that time and getting to hospital. So, and welcome it. I understand it from my background, but at the same time, I'll be robust and challenging it if it's not appropriate, because I understand the pressures you guys are under in terms of monetary recruitment and establishment levels and stuff, and there is that balance, and you guys, in your level of seniority, have the responsibility. But that's great. You touched on stress there again and again, and it's been well mentioned. And the chief executive briefly mentioned some process that they're going through at the moment in conjunction with the union, looking at welfare and stress, particularly in around PTSD. Given the nature of the job and the scenes that the staff work under, it's bound to be prevalent. Do you want to briefly give us a wee indication of what actually is specifically being done for that in and around that?
Okay. It's the, I guess when somebody exhibits in our service with PTSD, we do link through our occupational health services and provide the support that's required there. In relation to, in the widest sense, the stress that happens within our staff, and the subgroup that I talked about, which has just started, it's a health and wellbeing forum, and it's about looking at ways that we can support staff more and market more what we can do for staff. So I think the first meeting of that group was 2 weeks ago, yes. And from that we've already had a communication out to all staff, reminding them of how to access the confidential counselling and what's required within that and how it's there to support them, etc., etc. So there's a little bit of a trying to make it live again and reintroduce it to staff so staff are thinking about it. Is there anything else that you wanted to?
Well, the outcome of that group, which is primarily composed of staff, I have to say, from all across the trust, is that they will get together now and develop a plan, looking at things such as peer support, if it's which is a very useful way of, and a very quick way of dealing with issues in real time. Also, support services such as care call, as we mentioned, and just I suppose it's a big milestone for us to actually get that group together, because again, all too often we have people go, they do a job, they finish it and they get their next job, and we haven't accounted for what's needed in dealing with their needs at that time. And this engagement process that we're going out to are involving staff in will give us some feedback in terms of what their needs are and how we can best meet them.
Can I just give an example of an intervention that we've put into our control room? Because again, staff in the control room, as you would be aware, can have to deal with some very distressing calls, etc., and stay with the patients until the paramedic and technicians get to them on the phone providing advice. So we did get our care call people to come in over recent weeks and be available within the control room, and that gives our staff who have been dealing with some of the more distressing type calls to actually take time out with the counsellor in situ and have some input there. And that's one of the examples that staff have with their managers suggested, and we're trying to support staff in actually having a look at, and we'll use that as a test case to pilot and see what, does it work, has it worked for staff, has it been useful, and how we can continue to roll that on out. So
okay,
yeah,
that's fine. I have a third question, but I'm going to let you answer it together if that's okay. So I'll leave it to the end, and then you can decide, because it is a cumulative effort in terms of I'll give you a hint, it's about Desert Creek. And I have a bias towards it because I was involved in the initial project. Okay, so I'm going to move on to the fire service. And Gary, you talked earlier on about the lack of fire calls, retained firefighters, and I would obviously coach return gamekeeper in that firefighter safety I know is a key priority for yourselves. How do you propose to address that? I know Desert Creek, which we'll talk about at the end, is coming up. In the interim, before that facilities there, what is the strategy for ensuring firefighter safety levels are met through an involved training strategy? Or
Well, thank you for your question. I mean, there is a training strategy that exists at the minute. I mean, we can talk about our training facilities not being fit for purpose in the light of Desert Creek. That's a different conversation. But we're very focused on regarding the training of our staff, whole-time staff, not so much because they're there 24/7, so they're doing continuous training and drills on a day-to-day basis. But our retained staff that aren't there, they've got a 2-hour drill night once a week, and that drill night, which is called a drill night, is no longer a drill night anymore because things have changed and the paperwork that needs to be done and people's electronic computer access, etc. So we have a thing called safety critical days, safety critical training days, and every retained firefighter must do 12 safety critical days. So that's non-negotiable, and that's what we do in the retained world. So all of those staff, the 994, the complement we have, will have to go through it. That's the bare minimum that we require for them to be trained adequately to keep them safe. And that's what we're maintaining.
Do you see any pressure in those 12 days in terms of budgetary constraints? In the past, a few years ago, there was pressures on the training budget, as there was across that. Firefighter safety, for me, it's an absolute given that that's something that can't slide.
There are pressures. There's no doubt about that. We would have had a two-prong approach. So we would have had training for retained firefighters, and then we would have had exercises. So exercises is like the validation of the competence that's gained through the training. And we have had to put out a moratorium on exercises because the money's not there in the budget to be able to do the exercises. But we've tried to build the exercises into the safety critical training days. So the front day will be loaded with regard to training for competence, and then some sort of scenario-based exercise at the end to assess that. But yes, there are budgetary pressures, but we're not compromising on the training of our retained personnel.
Okay. I did have another couple of questions. It's not favouritism. I'm not going to give you them because, apart from the Desert Creek ones, what I'm going to wheel out now, because you've been sitting there a long time. So Desert Creek, as I said, we've got the right people in the room at the right time now. Okay. I was on that project and it was frustrating that the ambulance service weren't there. That's just my cards on the table. And there are reasons that I don't know why they weren't there. I noticed the Minister has now made a statement this morning saying that the design team has been appointed and we're looking at a £45 million build project on the back of Lurgan and co-responders. I'm assuming that the ambulance service didn't provide the training for FPOS, the first responder. Is there any reason why the discussions wouldn't be ongoing now as to why the Community Safety College wouldn't have the right people in the right place, looking at the synergies, looking at the savings, looking at the increased training opportunities and standards of response that the taxpayer should get?
Perhaps I can lead off and others can join in. Robbie, thanks for the question. Welcome the fact that it was with the Minister yesterday up at the site. It's great to see the design team appointed for the enabling works. The enabling works don't sound very grand, but for us they'll take a lot of pressure off us because immediately it'll give us our tactical firefighting training facilities hopefully very quickly. And it's an exciting prospect. The prospect of a fantastic facility and all that might bring. Where we are in relation to the project, you'll be aware that the OBC1, Outline Business Case 1, was approved by the Executive, which gave us the approvals to take forward what we're involved in now. The design team now will go ahead and design those enabling works for us, or develop the design of those enabling works. The next process we have to go through is OBC2, and that is really about the wider project. And certainly we've had conversations, Roisin and I, and there's been lots of talk about it in various forums about who should be part of this. And I think we really need to, in the process of developing OBC2, we'll look at the detail of everything that's in line with any normal business case process. We'll look at everything that's required and the strategic context and who might be involved. And I would absolutely welcome the ambulance service getting much more involved in that development. But I think we should probably be a little bit more widespread than that. It's not why stop at the ambulance service. We do a lot of work these days with voluntary agencies, people like Community Rescue, Foil Search and Rescue. There are various other agencies that may benefit from some of the things that we do in relation to command and control. I know worked very closely with colleagues in as it was then, DOD, a couple of years ago when we had a major incident in the spring blizzard and whatever it is, and they were very good. But there's got to be potential for us to look at the wider public service and how we might develop all of those capabilities. All of it will benefit the public in the long run.
I agree with you, Dale. I would see those other functions as complementary to the normal bread and butter and daily, and the bread and butter and daily would be, would you guys provide 24/7? So I do welcome, and there's nothing wrong with that. So, rushing or...
Okay. I think in the early stages, I know we did have some conversations at the very early planning stages. I know our emergency planning officer was involved in discussing what NIAS needs, etc. would be there. I suppose I have to say we are a small trust and would be a small player within that. At this point in time, we're in discussions with the Department of Health in relation to the education model for paramedics, and you'll probably know that in other ambulance services nationally, paramedics are mostly being trained through university setups. So the bulk of our training at the minute in our training school would be actually the training of our paramedics and subsequently our technicians and that. So in terms of the activity that we would have to be a main player in Desert Crate, it is not clear at this point in time, but I would suspect that it's not at the, it's not at the level that would be needed to be a key player in there. However, we're very excited about it in relation to shared emergency planning type training, and certainly would be very keen in that, particularly with the opportunity it gives for Northern Ireland to work on emergency planning. Quite often our emergency planners go across the water to some of the training events over there, and it would be very, very useful to have that there, and we certainly would want to use the facility if we were able to when it's up and running, and we'll continue in OBC to explore that and to see if it does meet our need in any way.
I would encourage you to do so, because a £45 million investment by any department in any single organisation, for instance, is good, and we need to get value for money. And I know you referred to emergency planning and emergency response. Those are the grand scale bigger events, obviously, and I just think there's a lot of synergies and savings and professional sharing of training that could be benefited from. Thank you.
Absolutely.
Thank you, Robbie. Paula? Oh, sorry. I didn't realise I thought Kat was in front of me. Thank you very much. And it's some going, this, isn't it? I just wanted I've two questions, and unfortunately they're both for the ambulance service. Earlier on this summer, the Health and Social Care Workforce Census came out for the year ending 31st of March 2016. And worrying for me as a woman, only 25% of your staff are women. 19% of your rapid response vehicle paramedics are women, and 18% of the ambulance officers are women. I'm just wondering, first of all, do you think that that's acceptable? Why is that happening, and what are you doing to address it?
Okay. I think, is it acceptable? I think it needs to be reflective of society. So I think that would be the ideal, that we could see a change in that dynamic. I think over years we have seen a change in that dynamic. What we are doing about it, our recruitments are based on best practice. And unfortunately, what we seem to attract is less women. What we seem to appoint is less women than men to the workforce. I'm wondering, can you come in just to discuss that in terms of your workforce?
Okay, I think we, as Rishin has said, we have attracted more women through recruitment processes, but not to uplift the percentage that you've identified to what would be an acceptable level. And I think that the reason for that is primarily not so much the nature of the work, but perhaps the shift patterns and all associated with that. So again, as we are starting to review that and looking at part-time working, that might make it more attractive to our female colleagues who would be interested in joining us. But having said that, I think it's fair to say we have made progress, most definitely, and not only in just recruiting to PCS, EMTs and paramedics, but we also have a lot of females now holding senior positions as officers in the service and in training, which is very encouraging.
I'm thinking maybe about positive measures.
Yes.
I recognise the
Yes.
good practice and guidelines
Yes.
stuff, but I'm
Yeah.
thinking about
Yeah.
positively going out there.
Yes, I wouldn't discount that. I think we do need to do more to welcome women into the workforce. It's certainly something that our Trust Board had discussed a while ago, and I know that HR staff have been working with the Equality Commission on some areas around that as well, and would intend to roll some of that work on out. I think, as Brian has said, there is a complexity in a 12-hour shift pattern that's largely full-time, and what, again, I think that you or I referred to earlier about trying to now look at new working practices through this capacity review, to look if we can look at different working patterns and different shift patterns, and that might make the situation different. I think the training as well historically has been residential type training for our paramedics and technicians, and obviously that training is changing now, so that whole environment will reshape and might be more attractive to women as well. But I do take your point, and it's not appropriate and it's not acceptable, and it's something that the Trust will do something about, and will make sure that women know that they're welcome within the organisation and valued within the organisation. I think, on reflecting on what our Director of Ops has said, we can see when women join the organisation that they can have a very successful career within the organisation, and that's good for us as well. But yes, it is an issue that we'll continue to work on, absolutely.
Okay, thank you. And I'm just going to maybe take in Robbie's point and Ian's at the start there. A couple of weeks ago I had a meeting with the HEMS campaigners, the Helicopter Emergency Medical Service, and when I was hearing them about that it's not just about the difference between what they're advocating and an air ambulance is. It's not about trying to get people to the hospital as quickly as possible, but it's about treating them at the site in terms of head trauma or punctured lung, or in terms of that. And I just thought, would it not make sense for ambulances, especially in rural areas, for patients to be packaged up at the roadside to mitigate against the impact of head trauma, as I say, so that they're then transported, as opposed to just doing the bare minimum, not the bare minimum, but doing the basics, and then taking them to the
I think
hospital?
The model, which but is still under discussion, but I think the model for the HEMS is around having a doctor as well as
and
a
that's my
paramedic
point.
there
Why
as well.
is there not for those category A, especially where there's a required distance and stuff?
So I'll pass over to Brian.
It's you have just identified it yourself, it's the packaging and the complexity of the packaging. So our paramedics are trained to a certain skill level, and to enhance that skill level would be would be expensive, and then to maintain that skill level would have a recurrent expenditure, most definitely. But our paramedics, if they come to a scene and they call for an air ambulance, they will sustain life in terms of being able, they will do what they can for the patient to the best of their abilities. But on some occasions, it takes a doctor, a specialist air medic, to package, and then having done that, to monitor them. And to go back to the earlier question of, why not have a ground landing area and transfer them? There's a lot of risks associated with taking somebody out of a helicopter and putting them into a land-based ambulance to bring them to a hospital again. So it's a science of medicine in its own right, and very complex equipment associated.
But my point is, and I don't have the same issue that Ian has. I appreciate that if they land at the top, then there's a lift straight down into the trauma room or something. So I absolutely support the investment in the Royal in that regard. My point is that if there's 37% of calls are category A, and then again they could possibly triaged, I'm not saying a medic on every ambulance, I'm just saying, would it not be, as a model going forward in terms of the reform of health and social care here in Northern Ireland, would it not be something in terms of long-term patient outcomes, a good thing to look at around having medics in those very, very acute response calls?
It would be, absolutely. And that would go back to the review that we're doing on workforce and the associated education and training with that. That is most definitely
potential model.
Something we could look at.
Okay, thank you. Thank you, Chair. Thank you, Paul.
Jerry.
Thanks. Thanks for the presentation. Just a few points, mostly for NIAS. And staff that I've been speaking to have said that there's been several occasions, quite often, where they've got 2 Category A calls at the same time, and quite often they're having to pick which one to go to. That's obviously an awful situation. So, I mean, in your opinion, Roisin and Brian, do you think we have enough ambulances on the road and staff to the service, the staff employed in the service? Just on, Joanne touched upon it, but if you could elaborate on private ambulances, how often are they used, and can you give us a figure in terms of how much they're paid to provide the service? And I think towards the end of your report, it says there was 1.2 million cuts last year. Just want to ask, where have they been? And I think you, at the very start, Roisin said that population increase is one of the reasons why it's harder to get to reach the targets for Category A's. Would you think that, given the scale of increase in Category A's, actually funding needs to be increased and need more funding in the service rather than less?
I think I'll start the answer by saying we wouldn't turn away additional investment if it was coming our way. It's obviously something that would be very, very welcome. Have we enough ambulances to do what we need to do? Well, if what we need to do is meet the ministerial target that we're not able to meet at this point in time due to the complexity of issues that we've talked around this table and perhaps some more, that will be highlighted through the capacity review, then I think there may be a story to tell in terms of requiring initial more investment in that as well. In relation to the financial savings, we have worked that through outside of the front line completely. So we've looked at equipment, administration, and some areas within our patient services side of the house to protect the frontline service within that. And that's where we've addressed our savings, and we've done that without any recourse to...
So can I jump in? Sorry, okay. It's administration and what else, sorry? Administration,
things like medical equipment and the budget for medical equipment, etc., and our PCS service is the areas that we have taken the money out of last year. So we do prioritise the frontline service, and we'll continue to do that. I think you asked me so many questions, I'm maybe going to have to answer them for you.
Private ambulances.
Private ambulances, okay. Okay, so and again, I think, you know, if we get to the end of our capacity review, we'll have some evidence and some science to give back to Health Committee and others in relation to what the exact...
Do you have a figure at the minute? Is there a figure at the minute for how often and how much...
Oh, sorry, I'm still on whether we have enough ambulances ourselves. Okay. So I'll pass over to Brian to talk about the use of private and voluntary ambulances.
Okay, I don't have a figure at the minute, but I can certainly get you a figure in terms of usage. And the way that has been operating traditionally, we would engage voluntary ambulance services as a first option if the whole system is in pressure. And that usually happens over the winter period. So we would get a call, for example, on a November midday to say that the Royal need to do 15 discharges to create capacity. And with our available resources, we couldn't deliver on that in the time they need. So we would engage the voluntaries. They would come on board very quickly. We would get patients moved to the appropriate facilities, and the whole thing starts to flow again. So that's how they traditionally were used. We then started to go back to the earlier point where the question was asked about our compliance with shifts, where we knew that we were going into, for example, a weekend where we may have been dropping a number of shifts. I made the decision to engage voluntaries and private services to come in to cover those shifts or those hours as far as possible, and they would be allocated low acuity work, so they'd be allocated routine jobs, moving patients between facilities, where basically it's more of a transport or mobility issue, to release capacity on the paramedic end so that they could deal with the Category A call, so that they're basically not to take some of the workload off them.
And that has benefits in two ways. It's a very flexible way of up and down your resource levels, and a very economically value for money way. But also, it enables us to support the voluntaries, because part of our major incident plan is, in the event of something untoward happening, that we would activate the voluntary and indeed the private to come and support. So it keeps them basically within our family. It keeps them, I feel like, practicing what they do, and that we know that if we call on them, that we've formulated that relationship and they can deliver for us. So it's not that by any means, it's just a way of delivering the service. But I think that sometimes what happens is that some people look at voluntary and private crews outside of an ED department or a hospital and assuming that we are engaging them all the time, and we don't. Because quite often what happens is the trusts themselves have contracts in place with voluntary and private ambulance services, which is outside of our remit. I know that this has been an issue within the Health and Social Care Board, and they're now starting to look at that and see who is using them, how often are they being used, what way has it been regulated, and that's work that's ongoing.
Okay, thank you. We've got Catherine and then Mark.
Okay, thank you, and can I thank you all for coming today and still staying here at this late stage. We appreciate that, and I know it's been very trying. A lot of my points, in fairness, have been covered, as you can imagine. So my questions will be slightly briefer, but I'm sure you won't complain. So I'll go to the ambulance service first, and just to put on record my thanks to all the staff in the ambulance service. The ambulance service staff work long hours, often with little to no breaks, and I know that that's a choice to make because of the fact that there are staffing issues. The concern has been raised around sickness levels, often being due to an inability to maybe access time off, which is required for anyone's well-being. So it's really just to ask you a question around ambulance staff's relationship with the trust, and what actions have been taken to harmonise that, given that there has been a breakdown in relations over the last number of months and years.
Okay, Brian.
Okay. I suppose the first thing I have to say is that when you refer to staffing issues as being the sole point of pressure, that isn't the sole point of pressure. Staff do have to work and have worked harder over the years, but that has also been attributed to the increase in demand. A 5% increase in demand every year is a big issue for us and a big issue for our staff. So I think that in terms of what we're doing to improve relationships, we are trying to make the whole system work better for patients and work better for staff. So we certainly would admit that there are, for want of better terminology, some industrial relations issues that need to be addressed, and we have systems in place to address those, and working groups to try and reach solutions on those issues. But a good example that you've given is working long hours and not getting meal breaks. They don't get meal breaks because we don't decide not to give them to them. They get meal breaks because the next emergency call is waiting for a response. So therefore, the question for us is, do we have enough? That's why we've pushed on now to have a review of our capacity. The outcome of that will be, well, are people starting and finishing at the same time and requiring meal breaks at the same time? Do we need to adjust that? So we are committed to doing what we need to do in making the service for patients better, but in doing that, we also believe that with reasonableness prevailing and a willingness from our staff and staff-side representatives, we could make it better for them also. But that's notwithstanding the support that we will need from our politicians, from the people who commission the service. It's a big change. We're transforming, and certainly in my 31 years in the service, and someone who hasn't had meal breaks and gone through all of this, I do empathise with what's gone on the ground, and I do see that we have gone through a very bad time, but I do believe we're coming out the other end.
And there is a willingness from all of the stakeholders to see the organisation being on a better platform. And I think that the Chief Executive has outlined some of the challenges and some of the ideas that are putting forward, and I think that will deliver.
Okay, and just a wee side question in around that. If staffing issues do come out of the capacity review as a problem, for example, not having enough staff, or certainly how staff are eroded in, have you the budget then to recruit more, or is there an issue with your budget that is stilting that ability to increase your staff membership?
Yeah, our budget is static. It is our budget, and if the process that we would undertake, if there was, if we were making a bid for more money, we would do a business case, and that would go through to the commissioners in relation to that. So yes, we don't have. We're spending our money, and we're largely spending it on frontline. Much like the picture of our staff, 80% of our budget goes on frontline as well. So you know, that's where it is. So depending on what comes out of the capacity review, there'll be some discussions to be had and some business cases hopefully to be developed.
Perhaps we're being a little optimistic in the last recruitment that we did. We have just last week committed to interviewing all of the 320 people that are shortlisted, so that should funding become available, at least we're on the starting line.
Not waiting lists.
Yeah.
Yes.
Did you mention when the capacity review would be completed?
We're doing the procurement bit of it now and trying to get the approvals process in place. We're hoping to go out late October, early November, as long as we get through the. I'm sure you're aware of how complicated the procurement processes can be in this regard, but we're hopeful that this year will be as in this financial year, we'll get to the output of the capacity review. That's certainly what we're aiming for.
Okay, thank you, and thank you for your responses. Thank you to you two as well, and for waiting so patiently. Just to commend the cooperation that is going on in my constituency and Joanne's constituency of Upper Ban. Stephen Boyd kept me informed along the way as this was progressing, and indeed updated me when it was due to go live. And it has to be welcomed. I mean, to support each other in that way, and one day that might come back, the ambulance service may be able to provide support. So I think that has to be welcomed and commended, and support has to be given to that. My question is around the fire service, similar to what Polly asked the ambulance service, about a lack of women and the barriers to women maybe possibly applying to the fire service. There maybe is that perception out there that, you know, it is all about tackling fire, but your role has changed so much that women would be assets to the service, and I'm sure you agree to that. What actions are you taking just to tackle the barriers and to bring them down that are stopping women from applying? Okay,
first of all, we've around 56 women at the moment, some whole-time and some retained. And this is a thing that comes up now and again. People say about women in the fire service and it's suitable. And I used the same example all the time. I think I used it to Paula the last time we talked. If you go to St Paul's Cathedral and come down to the river from St Paul's Cathedral, there's a monument there to all the firefighters that were killed in the Blitz, and a significant number of them were women. Now, if they were good enough to die at probably the worst time in living memory for putting out fires, then my view is they're good enough to be in the fire service now. Every time we recruit, we go out and we try to do some positive engagement to encourage women to apply. And in the past, perhaps shift systems and things like that haven't been the most conducive. We will look, depending on the situation, at flexible working practices where that's possible so to do. Another issue that was raised in a previous recruitment, we haven't done any whole-time recruitment now since 2011, but an issue that was raised then was around the fitness testing and around the use of the multi-stage shuttle run for fitness testing, and we've taken that away. We're going to do the fitness testing now at a much later stage of the process next time we recruit. And also we've reviewed the whole aptitude testing process to make sure that it's fit for purpose and actually reflects what we need the people to do. But in terms of the next recruitment programme, it's my plan, well, it'll be Gary's plan now, he'll be taking over from me shortly, that we get out there and do as much positive engagement as we can. What I will say is that in the last retained recruitment process that we did, which was much more recent than old time, we did get a good number of female applicants. Our target is to achieve 10% applications and 10% appointees. We've never got near that. As we said at the moment, 2.9% of our full-time workforce are females, and 3.4% of the retained workforce. We recognise there's a long way to go, but certainly there's a willingness amongst the corporate management team to try and address that imbalance.
Thank you.
Thank you, Catherine. And just for marking, can I just remind members, we have quite a few statutory rules to rattle through, and we need a quorum. So just bear that in mind. We'll rattle through them as soon as we're finished here. I promise we'll get through them pretty quickly.
We expect a rapid response. Again, I'd echo all our members' appreciation for both organisations and the heroic efforts of your staff, your respective staffs, on the front line. The first issue I'll touch on, and I thought Jerry was going to go there when he started asking about fleet, and he was talking about number of ambulances, but I know there had been a historic issue with fleet, and that some of it was historic. To be quite frank, it wasn't deemed as for purposes going back a couple of years. I was just wondering, had those issues been addressed? Have the ambulances that we do have, albeit we may not have enough of them, are they all state of the art and roadworthy, I suppose?
Yeah. Well, thankfully, the answer to that question is yes. We have had a commitment to annual fleet replacement programme funding, and all of our vehicles are less than 5 years old, and they are state of the art, and the equipment in it is the best you can get.
That's good. That was rapid. Another issue, and I'm aware again of the work of both organisations in conjunction with other statutory agencies and government departments and the road safety forum and various partnerships around that. Now, this again mostly goes back to ambulance service, though, whenever we're talking about response times and failure to meet response time targets, particularly in rural areas, which are traditionally and historically and statistically the most dangerous roads. Well, over the past couple of decades, we've seen a huge reduction in the number of deaths on our roads. Sadly, for the past couple of years, we've seen the figures around actual deaths on our roads creep up again. However, strangely, the number of serious injuries received on our roads is going down at the same time, which would suggest that maybe the issue does lie with emergency services getting there or getting the people to hospital on time. I know there's such a fine line, I don't need to tell you guys that, between life and death, and every second counts, literally. But it was a real anomaly in the figures, and I'm sure your colleagues who work in that specific area could maybe explore it further.
Okay, and yeah, that's a very complex question. I suppose my first thoughts would be management of trauma is a very specialised business, and I suppose it's more of a plea in that there's only so much you can do at a scene, and so much you can do in transporting the patient to hospital. That's why we have specialist ED departments that are designated as trauma centres, and our staff are faced with some very difficult cases to go back to packaging the patient and transporting them to an ED, but really what they need is specialist consultants, the specialist scanning and x-ray equipment to be able to deal with the multi-system trauma that they've experienced. So quite often, as you've just identified, we will arrive on scene and the patient will be dead on arrival. If they're not, then they will do the best they can, but they are very limited in terms of complexity of case.
Been critical of staff or the service, but I do think it's possibly indicative of just how stretched the service has become. And on that, and you spoke there of the increase in demand of 5% year on year. I wonder if you could maybe sort of expand on to what you think that is attributable You know, I know some of us will see occasionally in the newspaper there'll be articles on the type of 999 calls that are received, and a lot of people will look at them and laugh, and the way they're presented in the paper is almost as a humorous article, but it's a very, very serious issue when there are people making phone calls, wasting time, tying up resources, and what more could be done, I suppose, in an education sphere as well, because there are other people who ring an ambulance because they think that's what you do when you've got a headache. And what more can be done to educate people around that? And again, it's something we have discussed about people turning up to A&E with toothaches and stuff too.
I think there's all sorts of. It seems everything we're going to talk about is complex, but there's all sorts of aspects to that, because there will be some people that will ring 999 because they do have a need, but it's not necessarily a 999 ambulance need that they have. So it's about making sure we don't discount those sorts of calls that maybe aren't right for the ambulance service, but we do need a pathway somewhere that they can land to. And then we also have the spurious type calls that we're trying to work through our community education programmes with, and some of our media campaigns, and certainly social media is a good opportunity for that as well. And Brian, is there anything else you wanted to add on?
Yeah, I think there's a couple of factors on top of what Roisin has given. I think there is sometimes confusion on how to access health services, and people see 999 as a very quick process with a guaranteed response. But I think that we may never change that. You know, public education will help, but I don't think it will ever make it change completely. So what we need to do then is look at how we deal with those calls and downgrade them, not as 999s, but through things we've put in place, a directory of services, which basically on our control system we know where all of the GPs are, dental services are, all of those things, which we would like to build on. A call will come in as a 99, it could be passed to another team, having been determined that it's not a 99, and then they would manage that call appropriately. It might take longer time, but at least it'll deflate the pressure on the system. And the other thing we brought in is a clinical support desk. So if a call does come in as a 999 and it's not a life-threatening call, we actually have GPs in our control room who we can pass the call to, and they will say, okay, you don't need an immediate ambulance response. That's the first thing out of the way. Now let's talk about your needs. What is the problem? And that may be, you know, something as very simple as a single mum with a few kids, and one of them spiking a temperature in the middle of the night, and she's no care arrangements to be able to take them to. They will talk them down and say, okay, give them this, I'll ring you back in half an hour. If it gets any worse, you ring me back first. Those are ways of being able to address the demand issue.
Yeah, and I know there are two people out there who see arrival by ambulance maybe as a surefire way of leapfrogging the other people sat in the A&E waiting room. Just in terms of the issue raised by Paula and Catherine, that was around attracting females to join both services. I think what's sure to put people off, certainly women off, joining the ambulance service might be this increase in attacks on staff, and I think the attacks on ambulance staff are very different in nature. The attacks on fire service, where it might be a lot of young fellas throwing stones as you drive past, where ambulance service, it's more attributable to you arriving in often combustible situations that you can't really educate the public about, although they might be reflective of other wider societal problems. I'll touch on fire service now very briefly, Chair. Just in terms of, I was chatting there about waste of time, hoax calls, the amount of waste of money or resource that you, not that you are wasting it, you have to go out, you have to respond to calls, but the likes of bonfires is one that always grabs the headlines. That is a couple of nights a year, but gorse fires as well is always a big drain on resources for yourselves. I wonder if you could maybe outline just off the top of your head, cost of such things to yourselves in terms of the financial cost, let alone the potential human costs?
Well, the cost varies. Ghost fires, rural firefighting is something that's very difficult to predict. We had a really bad year in 2011 where we had the busiest day ever. I was in the command room, and our very busiest day in our history was in 2011. It was ghost fires, and we were completely stretched. And it's never been as bad, thankfully, since that. A big factor in that is the weather, and the weather hasn't been that good for the last few years, so that's something that has definitely been in our favour. But what our guys have been doing and been in a really good job of is engaging with people to try and prevent these things, because largely they are preventable. People, for whatever reason, burn things in the countryside. If you make them aware of the consequences and what might happen as a result, usually they'll listen, and we can do something with that. And we've seen a marked reduction in our ghost fires over the last few years. The costs really largely depend on where they are as well. A ghost fire on the Belfast Hills it will be attended by whole-time crews, so we're paying them anyway. A massive ghost fire in the Mons, which maybe goes on for 2 or 3 days, will be attended largely by retained crews, which we pay by the hour, so that's a much more significant effect on sort of our budget, if you like. What I will say is that the work that's been going on has been very productive. The people have been engaging, people like forestry, people like the local communities, the farmers and what have you, have been talking to us, and if we keep on that trajectory and keep engaged with people, I think this should become a much less significant problem for us in the future.
Thank you, guys.
That's great. Thank you. Thank you very much. I know it's been a rather long session, but I suppose it's been a double witness session.
Absolutely.
Having both of you here, and it's good to have you both together. Just before we finish on it, I just want to tie a few things down to do with what Trevor and Joanne had both highlighted earlier in some of the asks that the committee have asked for. Look, I know, thankfully, Catherine had asked about the review, capacity review. That's in and around March, so we might get you back again, if not before that, back around just after that, maybe even around June time, to see where that's going to go. On that capacity review, now I might have picked this up wrong, or you can tell me differently here, the part-time hours and the shift patterns and stuff like that, are they coming into effect?
They'll all be fed into the capacity review.
Right, okay, so they're not going to happen until the capacity review takes place, and then that'll be part of
the
that process.
recommendations will
That's
come out
okay,
of the capacity
because I know
review.
with the issues Trevor and Joanne raised to do with the drop shifts and different things like that, I do actually believe that different shifts, and especially part-time, could make a big difference there. So if we can just get a little bit of information back from you, Brian, on even the past performance over the past year, whatever that might be, when that's happened. We're not. I know I've worked in the health service. I worked for a number of years in it. I know we rely on goodwill. And it's the same with yourselves. We rely on goodwill from anybody that works within that service, and I know goodwill gets stretched to the point where there is then sickness levels and things do happen, and sometimes accidents can happen as well because of those issues. And we want to do whatever we can to help with those issues. And I think that's the general feeling around the table. As long as we have the honest truth in front of us, we can do whatever we can then to try and alleviate some of those pressures. That's what we want to do. So if you can get some more information back to us, we can keep an eye on that as well. And I think then once the capacity review is done, that'll give us some real positive direction to go with to alleviate those pressures. Is that fair enough to say that?
Absolutely.
Okay, so if we can get that back.
Thank you.
And you guys, thank you so much. It's good
Thank
to see
you.
you again.
Thank you.
And thank you. A very informative session, and thank you, members, for bearing with us on all of this.
I thought we were great.
We thought you were great too.
Okay, members, we will move swiftly on because we have got these statutory rules, and it all has to be formally read into the minutes. So we need to make sure we have a quorum still in the room. So if I can ask members if they could move on to item number 5, on the agenda, and that is our statutory rule 2016/249, the Food Information Amendment Regulations Northern Ireland 2016. Can I refer members to pages 353 to 362 of their papers? The committee considered the approval of the SL1 policy document for this rule at its meeting on the 9th of June 2016. There have been no changes to the policy content since the SL1 was submitted to the committee, and the examiner of statutory rules has no issues to raise. Are members content with the statutory rule?
Yeah.
Yes. Thank you. If so, I now have to put this formally to the committee that the Committee for Health has considered SR 2016/249, the Food Information Amendment Regulations Northern Ireland 2016, and has no objection to the rule. Are members agreed?
Agreed.
Thank you, members. I'll move you on to item number 6, which is SR 2016/251, the Food Safety Information and Compositional Requirements Regulation Northern Ireland 2016. Can I refer members to pages 364 to 378 of their packs? The committee considered the approval of this SL1 policy document for this rule at its meeting on the 9th of June 2016. There have been no changes to the policy content since the SL1 was submitted to the committee, and the examiner of statutory rules has no issues to raise. Are members content with this statutory rule?
Yep.
Thank you. Therefore, I read it formally to the committee that the Committee for Health has considered SR 2016/251, the Food Safety Information and Compositional Requirements Regulations Northern Ireland 2016, and has no objection to the rule. Are members agreed?
Agreed.
Thank you very much. Move on to item number 7, which is SR 2016/313, the Food Hygiene Rating Regulations Northern Ireland 2016. I refer members to pages 381 to 394 for the relevant papers. The committee considered and approved this SL1 policy document for this rule at its meeting on the 15th of September 2016. There have been no changes to the policy content since the SL1 was submitted to the committee, and the examiner of statutory rules has no issues to raise. Are members content with this statutory rule?
Agreed.
Thank you, and I've put it formally that the Committee for Health has considered SR 2016/313, the Food Hygiene Rating Regulations Northern Ireland 2016, and has no objection to the rule. Are members agreed?
Yep.
Thank you, members. We'll move on swiftly to item number 8, which is SR 2016/314, the Food Hygiene Rating Transitional Provisions Order Northern Ireland 2016. May I refer members to pages 396 to 403 of your relevant papers. The committee considered and approved the SL1 policy document for this rule at its meeting on the 15th of September 2016 also. There have been no changes to the policy content since the SL1 was submitted to the committee, and the examiner of statutory rules has no issues to raise. Are members content with this statutory rule? Okay, thank you. Therefore, I'll put it formally that the Committee for Health has considered SR 2016/314, the Food Hygiene Rating Transitional Provisions Order Northern Ireland 2016, and has no objection to the rule. Are members agreed?
Agreed.
Good stuff. That's those done. Thank you, members. We'll now move on to item number 9. Which is matters arising, and may advise members that the RQIA's response to the committee's request for further information on the review of renal services can be found on pages 405 to 443 of their meeting pack. I know this is something that you had
Yes,
raised.
Chair, and they did come back to me very, very quickly on that, which I'm pleased about. So I'm taking that forward, so well pleased with yours.
Okay, so members happy enough to move on. Can I go to item number 10, which is correspondence? And advise members there are 10 items of correspondence at pages 446 to 617 of your meeting pack. Can I refer members to item 10.5 from the Committee for the Executive Office, which is coordinating committee responses to the Programme for Government? Are members content that we forward our response to that committee once it's ready? Thank you, members. Can I also refer members to item 10.8, which is a copy of the Prisoner Ombudsman's recent report on the self-harm incidents by a prisoner in Maghaberry Prison in 2014. Members, given the serious nature of this report and the number of recommendations falling to the South Eastern Health and Social Care Trust, as well as our own declared interests in mental health, can I suggest that we write to the Trust to inquire about its response to the recommendations, and then once we receive that reply, we then decide where we want to take that further as a committee. The members agreed with that?
Agreed, yeah.
Okay, members, thank you. Are members otherwise content with the proposed actions as listed in the correspondence cover sheet?
Yeah.
You're jumping ahead of me, Mark. Can I now refer members to tabled papers? At page 9 is correspondence from the Minister regarding a proposed legislative consent motion in respect of the Health Service Medical Supplies Bill introduced in the House of Commons on the 15th September. Are members content that we seek a briefing from officials as soon as possible?
Yes.
Okay. Also in tabled papers at page 13 is an invitation to an event called Boxing for Wellbeing. This is being run by TAMHI on Friday the 7th October in the good old North Belfast constituency in Girdwood Community Hub. Can I suggest members respond directly but copy in the committee office if they intend attending this event. And finally, at page 14 of tabled papers is correspondence from the Chair of the Education Committee. The committee is looking into cooperation between health and education bodies in respect of special educational needs assessments. The Chair therefore proposes that his committee proceed under Standing Order 64A, which would mean that the Education Committee would take the lead but would seek our views on this. Are members content with that also?
Yep. Yep.
Okay, members. Item number 11 on our agenda is our forward work programme. I first refer members to the committee's draft strategic plan at pages 619 to 622 of the meeting pack. Are members content with the strategic plan as drafted?
Yes, Chair, only no word yet on Bengoa when he's going to present.
Not on that, but if we deal with the strategic plan first, that was our plan that we had decided of where we want the strategy of the committee. Can we deal with that first? And we'll, yep, we discussed it in our earlier brief. Okay, thank you. As with Bengoa, I have heard nothing back as yet from the Minister. We're all still waiting on that, so nothing on that as yet.
It's 2 weeks, Chair, since this is our second meeting back. I think it's 2 weeks since we asked. Could we maybe
the 15th?
The 15th. So could we maybe contact the Minister again and push that?
Absolutely. Yeah. Can I also refer members to the draft forward work programme at pages 623 to 624 of the meeting pack. Are members content to note the forward work programme? Yep, thank you. Can I also invite members that further to our invitation from Professor Lawther to hold an external meeting at the Centre of Cancer Research and Cell Biology at QUB. We've now decided on a date, and that's the 17th of November. And we will also hold at that an external meeting and get a tour at the labs. Are members content with that? You get that in your diaries if you can let. I'm sure we'll be, or the clerks will be emailing you, but if you can let us know.
Okay, so I haven't got it in front of me, Chair, but just for travel to that, will there be a transport leaving from?
Well, we'll see what we need. We'll see if many people want that. If I suppose you will send round some emails and try and find information out on that.
Just Chair, there's also a men's health event on that day as well. Yeah.
I know. But the men's health event was taking place during our committee, which we couldn't have attended anyway, which is a bit of bad luck because that was in my diary also. But there has been.
Men aren't good organised.
No, they're not. No, I wouldn't say that. Actually,
can't disagree with that when you look at my diary.
I know that, and that could have been in for some time. I don't know. Yeah. I know the logistics of getting us to QUB and of what they have to do in order for us to be able to spend time there has been difficult for them to organise as well, and lots of diaries around that. I've had to move several things in order to attend this as well on the 17th because I had a few things. I've something here in the afternoon as well that I'm launching. But it is a date, I'm afraid, that we are have been asked to abide
could we
by.
make the group that's organising men's health aware
Yeah.
that it was there for us, and that
And that may well have, I don't know who's booked that, it may well have been booked before when they thought Health Committee was on a Wednesday afternoon,
Yeah.
and therefore we would have been able to attend it.
yeah,
But, so it's a bit sad
just in case
that
it gives
it was the same day.
it may not give them any scope, and it may not have been that important to them for.
Oh no,
That's what I
absolutely.
mean,
And it was, and it certainly was in my diary. Okay, I've now lost myself. Okay, finally. Can I advise members that I met this week with the Community Development and Health Network, and I think some of you met also with them. They're doing some excellent work across Northern Ireland, which connects in with our discussions about alleviating pressures on primary care and promoting public health. Can I propose that we invite Community Development Health Network to brief the committee not until the new year? I know some of you will have met with them. They're doing some excellent community work out there, and also working as part of community development. And I think they could feed in to some of our reviews that we're looking at. But I propose that they come here and actually give us an actual briefing, but not until the new year, if that's okay.
I think it's very necessary, having spoken to Joanne, because we'd be duplicating work perhaps because of the conversations that we were having with her. Yeah, that's excellent.
So, yeah, okay, is that fine? Okay, item number 12 is any other business. I have one item of any other business on behalf of Jerry, because Jerry had raised it earlier and said he had to leave. I know we've heard the issue around the young child who's been waiting on dental care for extractions. Jerry had originally been the MLA that had been involved with that and had been contacted over that. So I think we need to actually look at it as in a much broader sense now that we know that figures have been released. I think it said something around 5,000 children are waiting on that type of surgery, or to be anaesthetised to have tooth extractions or whatever else type of dental surgery done, which seems like a horrific amount of children for a start, never mind the waiting list for those. So I think I'd spoken to Jerry earlier, and we had proposed that we maybe write to the department to seek those actual figures, because it's maybe something that another piece of work, or maybe there's things being done through the PHR or whatever in educating not just children but parents as well around a good oral health, and I'd also be really interested to know what was that figure 10 years ago, what was that figure 5 years ago, to see has there been a steady increase, or
procedures that have to be done in hospital now that
yeah,
used to.
yeah, that's right, where there was a time that it could be done by a dentist. Yeah, so, but it's just we need to know those figures, and we need to know is there a spike? I know that I'm certainly a motion in a couple of weeks' time to do with childhood obesity will be coming to the floor, and it's very much been education based rather than health. But we need to look at this as well as part of that. Is there anything that we can be doing as a committee? So I think I've covered everything Jerry wanted me to cover on that. If I haven't, apologies, Jerry. Joanne.
Yeah, thanks, Chair. Yeah, I totally agree with your comment that we're all moved by the child and such stress, so very much welcome that. Can I just take the opportunity to thank members of the committee, and in fact other MLAs who attended in great numbers the Millions Missing campaign for ME on Wednesday, and I think it was very, very poignant, all the shoes and the apron at Stormont, which coincided 27th September with empty lives, wasted lives, people that haven't been able to fulfil their lives because of this very debilitating invisible illness, coincided worldwide with the Millions Missing campaign. And I know the group Hope for Fibromyalgia and ME were very, very taken with the interest of MLAs that attended. So just to put on record my thanks from the chair and the members of that charity. 7,000 women, or 7,000 people, quite a lot of women, but 7,000 people in Northern Ireland alone are facing a daily battle, and we know change is taking a long time to come. It's coming, but not quickly enough. So just to thank the members on their behalf for coming out in good numbers to support them on Wednesday.
No, thank you. I know most of us did attend that, and you're absolutely right. It did hit the stark reality when we saw all of the shoes laid out, and I think it was very well done, and it was well supported, and well done to the charity as well for organising that and for inviting us along. So thank you. Any other business members need to bring up? No, that's good. Can I move on to item number 13, which is date, time and place of next meeting? That will take place here in the Senate Chamber, 10:30 next Tuesday, the 6th of October, here in Parliament Buildings.